Good morning. I would like to welcome all of you to what is really the first symposium in the Department of Surgery along with the Department of Medicine on disparity in healthcare. As you know, disparity in cancer, the two words disparity and cancer have in common that it affects basically the entire nation, all of our population. Disparity and cancer are big issues that we are dealing with, and they're unresolved. What I wanted to do is just put a few words at the beginning about what we are dealing with. These are factors that result in health disparity. There's race and ethnicity, and we're all aware of that. There's gender, there's geography, but above all, and we'll talk more during this symposium today, there are differences in access of care, and that eventually defines outcome and many of the issues that we are dealing with. Income has an impact on it, education, behavioral factors, environmental factors, and cultural factors. Now, when we talk about cancer, we usually see slides that show hundreds of thousands of people that are affected. What is important, particularly for the medical students, is to keep in mind the patient you are dealing with is the 100%. The N equals 1 is the one person you are taking care of. The statistics are important, but a statistic of 100,000, an outcome of 100,000 doesn't mean anything to the one patient that you are treating and that you have to treat right so that that patient has a chance to survive. This shows you the impact of race on cancer. Breast cancer. African American women are nearly twice as likely than white women to be affected in it. The outcome is much worse in African American women than in whites. Kidney cancer, highest rate is in American Indians. Well, we don't see many Indians here, but where I was before, in Arizona, we had the largest Indian population in the country, and kidney cancer was a frightening disease. Liver cancer, much more common in Asians than in whites or in African Americans. Prostate cancer, African American men are most commonly affected by it. Cervical cancer, we don't see it often here, but we see it in rural areas. So if we go to upstate or to other areas of New York, that's where we encounter it. These are statistics from the surveillance, epidemiology, and end result programs from 2014. And it shows the incidence of cancer diseases per 100,000 people. If you look at it, first of all, men are more affected than women. 500 men per 100,000 will have some form of cancer, new cancers per year. Female, it's only about 400. Now, if we look at the ethnic distribution, white women have the most common incidence, followed by African Americans. The other ethnicity, much less so. However, if we look at males, look at this. Male African American are most commonly affected by cancer, followed by whites again, and then for both genders, the Asians have the lowest incidence of cancer. Where are cancer disparities noted? I already mentioned that they are noted when it comes to the incidence, the prevalence, screening rates, stage of diagnosis, and so forth. But it also has a more important impact on mortality, morbidity, on survivorship, and burden of cancer. Now, there are many factors involved in it, and some of them we can influence, some we cannot. The patient can influence physical activity, diet, chemical exposures, and so forth. Socioeconomic factors, healthcare access, and so forth is something that we may be able to improve for certain minorities, and access to care, equal access to care would be the cornerstone. And then what we cannot influence these days are the genetic and biological factors. And then the final slide really deals with what we have or have not achieved over the last 30 years. We have made tremendous progress when it comes to the treatment of hematological diseases. When it comes to solid organ cancer, we are still far from where we want to be. This shows the 5 deadliest cancers and survival at 5 years. For pancreatic cancer, only 7% of the people affected survive or are alive at 5 years. And you frequently have to ask yourself if the diagnosis was correct. You have to go back and look at the slides again, and Hopkins actually did that at some point, and they found that out of the 8% of survivors that they had, in 4% of the 7, the diagnosis was incorrect. Liver, intrahepatic bile ducts, lung and bronchus, esophagus, stomach, and so forth are also killers and have remained killers, despite our best efforts. So with that introduction, I also would like to introduce some of our leaders at Downstate. First and foremost, our president, Wayne Riley, and then our dean. Dr. Riley has made a major impact on the institution since he has come. I think one of his areas of focus is really disparity and trying to create a better chance for our minorities in our borough in Brooklyn to see Downstate as the academic center where we provide some of the best care in the country. So Dr. Riley, I'm honored that you are here, and we'd like to welcome you.
Well, thank you. Good morning, all. I am here to thank you for coming and to underscore the importance of this topic. Disparities is something I care deeply about, and making sure that our future physicians, our medical students, and our young physicians in training understand the gravity of the situation that we face in terms of taking care of patients, particularly in diverse communities. Cancer is, something that's touched everybody. I was reminded, Dr. Grusner, I lost a dear friend, one of my high school classmates, to multiple myeloma about 5 years ago. And this is a guy I had known since I was 10 years old. It just reminded me that it touches everybody. But this topic, again, is something that we all should roll up our sleeves and address. It's complex. There's genetic aspects. There's socioeconomic aspects. There's all sorts of aspects in terms of disparities. So there's not just one solution. There has to be a multifaceted approach to addressing cancer disparities, and that's why having conferences like this with experts you're going to hear from today are so important. I want to salute the two chairs, the organizers, Dr. Grusner, our chair of surgery, and Dr. Salafu, our chair of medicine. It really warms my heart to see that the chair of medicine and surgery work well together here. I've been in places where that isn't always the case, so I'm really gratified by that. So thank you, gentlemen, for your leadership. I care deeply about surgery. My late father was a surgeon, so I was raised by a surgeon. My late father was the chief of surgery at Flint Goodrich Hospital in New Orleans, and also on the faculty at Tulane, which was a storied department of surgery. He loved surgery, and his one regret in life was he didn't convince me as an internist to follow him into surgery. But he said he thinks I did okay nonetheless. But again, I care deeply about surgery and this great department and advancing care for everybody, no matter their station in life, what zip code they live in, what part of the borough they live in. Everybody should get a high quality standard of care. And this is why this conference is important. So have a good day. Thank you.
Thank you, President Riley. We also have our dean here, Dr. Lucchesi. I think it's important that we have representation from the College of Medicine as well. I think our medical students that are here, this is a very unique place. When you're done with medical school, many of you will go into residencies across the country, and you will go to places that look much more inviting than what we have. The buildings are new and not obsolete. But always keep in mind, what you learned here is something that very few of your peers can rival, and that is the diversity of the patient that you have here. Your patient here is your patient. You are his or her doctor. At other institutions, you may just be the first one to see that patient, and then the patient wants a second opinion or a third opinion, and has choices. Many of our patients don't have choices. Always keep that in mind. I mean, this is really public service at its finest. So I'm also honored to introduce Dr. Lucchesi, who will say a few welcoming words.
Good morning, everybody. I'll make my welcome very short. Welcome, for those who are not immediately from the campus, welcome to SUNY Downstate, the only academic medical center in the borough of Brooklyn, arguably the best borough in New York City, one of the finest cities in the country, one of the finest countries in the world, yet this exists, right? So today you can hear this symposium on the disparities in cancer care, diagnosis and treatment. There's disparities in healthcare broadly. So this is just one aspect of it. And I really want to thank Drs. Grusner and Salifu for inviting me here and talking about this extremely important topic. So enjoy your day, but more importantly, when you leave here, think about what you can do to help us change that, because it really is atrocious that this exists. And what Dr. Grusner said is so important. So William Osler once said, you know, don't treat the disease, treat the patient with the disease. And patients are all different. Diseases may be categorized in one area or the next, but the patients are different. And we have a very unique population of patients here in Central Brooklyn, and we should really do something to change this. So enjoy your day.
We also have the CEO of the hospital here, Mr. Walsh. Good education is only possible if there is a good hospital, and if you have the patients that are of interest for medical education. So without the hospital and the college working closely together, a good education is not possible. Mr. Walsh, Dr. Salifu, I, Dr. Lucchesi, many of the clinical chairs have set together to make this hospital really a hospital where many of the niches that at other hospitals are not seen are going to be treated in the future. I think over the next few years we will see a number of areas that we have not offered before that are new to the community, and I think this is going to benefit you, the students, and the residents quite a bit. Just one example, Dr. Poston, our new chief of CT surgery, just performed a couple of days ago the first robotic mitral valve repair in all of Brooklyn. You would think that would have happened, some time ago, but in many ways, we are behind whatever lies west to the East River. And I keep saying, we have to, for our community, build an academic center that rivals, the big centers in Manhattan. Because there was a time when Downstate, I remember that when I was a fellow, had just a glorious reputation across the entire country. We had Nobel Prize winners here, and we had programs that were stellar. Many of our faculty went on to become chairs at institutions like Harvard, Texas, UT Texas, and other places across the country. And with the support of the state, we hope we will get back to where we were. So I think it's important for our medical students, our residents, to understand that there are tremendous efforts going on part of the hospital to get back to where we were. Mr. Walsh, do you want to say a few words?
Thank you, Dr. Grusner. Good morning and welcome to Downstate. This is a very important topic. We're not doing our jobs if we're not doing right by everyone in our community. And the fact that, when you look at some of the indicators, part of Brooklyn looks more like the third world than it does like a part of the greatest city in the world, actually. So there's a lot that we need to do. We need, and as Dr. Riley indicated, it's complicated. There aren't simple solutions. But I think if you've got a chairman of surgery and a chairman of medicine that are willing to roll up their sleeves and work together and not worry about the turf issues, you're ahead of the game. So once again, welcome, and I hope you enjoy your time with us today.
Thank you, Mr. Walsh. One brief word, Dr. Riley mentioned it already. Surgery cannot exist without a strong department of medicine. Medicine is actually way ahead of surgery in terms of building new programs, and it is in great part due to the work that Dr. Salifu has given this institution over the last few years. I hope that surgery over the next few years will be at the same level as where medicine is right now. If we achieve that, I think we will be an extremely competitive hospital unit, because without surgery and medicine being at the forefront and leading the hospital efforts, we will not be successful. Dr. Salifu and I have a very close professional relationship. We meet weekly about all the issues that are important to our departments. As Dr. Riley said, this is not something you can take for granted. At many places, internal medicine and surgery fight over each other. This is not the case here. And I'm glad that my good friend, Dr. Salifu, was willing to partner in this endeavor to talk about the disparities in surgical cancer care today. So thank you again, Mauro.
Good morning, everyone. Let's do it the Brooklyn way. Good morning, everyone. Yeah, let's get some energy in the room. Okay, I have already been introduced, and my job is to introduce the keynote speaker. But I'd like to echo some of the comments that you made briefly, which is we are a team, right? We are a team. If we have that concept of team spirit, we can do anything possible for the patient. If we think that, you know, I'm the best doctor, you're the best doctor, you can't create a team that would be to the benefit of the patient. So that mentality really has to, the individual mentality has to go away, the team spirit mentality has to come in, and then with that mentality, you see that we can build a lot of programs and we can surpass the challenges ahead of us. So with that said, I'm enjoying working with you, and I was so happy that you brought this concept of the conference. I think this would, in the future, get bigger and bigger as we get more popularity with the conference. We can engage all the community physicians and the community hospitals in this program, and we can solve Brooklyn's problem in cancer. So today, we are very fortunate to have the Assistant Commissioner of Health situated in Brooklyn. His name is Torian Easterling. Could you come to the podium, please? Dr. Easterling had his medical education at the then UMDNJ in New Jersey and did a residency in family medicine and preventive medicine at Mount Sinai Hospital. He subsequently did residency and chief residency at Mount Sinai Hospital. He did some practice before he joined the New York Health Department and Mental Health. Currently, he's serving as the Brooklyn Commissioner of Health, assisting the Commissioner of Health for New York City, in charge of the population health, preventive medicine. He's a very accomplished physician. He's done a lot of work outside the country, including work in West Africa, where I come from originally, Sierra Leone, Gambia, and the like. He was also very instrumental in the earthquake in Haiti. That was many years ago, and Katrina in New Orleans. He mobilized groups to go and then do medical relief. So he's very, very vested in public health. He's very vested in population health. And in Brooklyn, he's helping to connect communities, create partnerships. He's actually working with Brooklyn Health Disparities Center, which I direct, to help develop some of the research projects that we want to do to address the health needs of Brooklyn. So today he's going to be addressing health equity. He's not going to be projecting slides, so don't expect slides, but he's going to talk in general, bring some greetings to you from the city, and give his perspective on what this is all about and what the city in general is positioning to address this issue. So with that said, thank you for coming, and please join me in welcoming Dr.
Good morning, everyone. Good morning, everyone. It's a pleasure and honor to be standing in front of you this morning. Thank you, Dr. Salifu, for the introduction, Dr. Grusner for the invitation as well. It is always a pleasure to be back here at SUNY Downstate, the sole academic medical institution here in Brooklyn. And it's also great to be here in this auditorium. I see that it's been renovated, so that's awesome. That's good. So that means that things are being refreshed and renewed. And so as already been mentioned, I serve in the capacity of being the Assistant Commissioner of Health for Brooklyn. Most people do not know that once upon a time for the Department of Health back in the early 1900s, there were about 30 some odd community districts. There are now 59, and each community district had their own public health doctor. Loss of funding, restructuring of the agency, that structure had changed, and so they then assigned the doctor for those community districts and combined them into one, and so there are assistant commissioners for each of the boroughs. And so I lead Brooklyn, and there's the assistant commissioner for Manhattan, and so forth. And so that has really allowed really some investment in key prioritization of programming and planning in certain neighborhoods and how we sort of lead the work for the health department. And so it's been an honor working with not only health systems, but community-based organizations and so many other stakeholders who are invested in the health and wellness of Brooklyners and all New Yorkers. And so quite often I hear, as Brooklyn goes, so does New York. And so many people do agree. I guess you don't, because I didn't see any call and response there. But it's been great to stand in this stead. And so the piece that I wanted to talk about, I've been asked to serve as the keynote speaker, right? And I do not have slides, and I really wanted to stay on key with the message. One, it's amazing that this is the first annual Disparities Conference on surgical cancer care. But also what is indicated in that title is that this is not going to be the last conversation. Am I correct? So what we hope to see is that there's going to be an involvement in the conversation. There's going to be measures and metrics by which we say that we have started here and we're moving forward in how our health system is advancing care, surgical care, cancer care, for all Brooklyners and all New Yorkers. And so I hold true to that message because that's how we measure our effectiveness as an office, to make sure that we're setting metrics and we're setting measurements to move forward the conversation, and so that we're not having the same conversation over and over. And for students, quite often what we see in this profession is that we will go to conferences and we're talking about the same issues. The data has not changed, as you've already heard from Dr. Grusner. We're looking at data 5, 10 years old, and the disparities exist, and they continue to exist. And for New York City, we're responsible for, our mission is to promote the health of all New Yorkers. But one of our main priorities has been to look at neighborhoods and understand how neighborhood differences exist in New York City. Our previous commissioner, Mary T. Bassett, talked about quite often that New York City is one of the most segregated and unequal cities in all of this country. And it is very true when you look at the maps of our health indicators as well as our social indicators. And so I can put up maps around cancer mortality, diabetes. I could put up maps of hypertension. I could put up maps of absenteeism for early education, poverty, rent burden. And what we see on those maps is that certain neighborhoods continue to have the worst rates, and not only the health indicators, but also the social indicators. And so let me say that again. What we often see in these maps, no matter what the indicator is, whether it's health or social, is that those differences exist for the same neighborhoods. And so for Brooklyn, those neighborhoods are Bedford-Stuyvesant, Brownsville, East Flatbush, Canarsie, East New York, and Bushwick. In Harlem, East and Central Harlem, parts of West Harlem. And you have Mont Haven, you have Tremont, you have Morrisania in the South Bronx. And the Bronx has, not only do they have certain neighborhoods that have the worst rates, but they also have to claim to be the worst county and being last, number not 62, as far as the county health rankings for the Robert Wood Johnson Foundation. And so when we talk about this data, when we talk about these numbers, we have to put it into context. Neighborhoods should not define, or zip codes should not define someone's health. And so if we're talking about a cluster or a neighborhood, then we're talking about groups of people. We're talking about the residents who live within that neighborhood. And so then that is not a biological conversation. We're talking about a social context. And so when we talk about disparities, we have to have a much larger conversation. And so here's the keynote, is that the much larger conversation is, how are we advancing health equity? Because the conversation of health disparities is incorporating this conversation of health equity. When we talk about health disparities, as you've already saw the list, you're talking about differences in groups. And so you can identify groups, and you can stratify them by race and ethnicity. You can stratify them by sexual orientation. You can stratify them by country of birth, etc. But what you miss in that conversation are things about the social context that have led to differences and discrimination that we have seen in some of the health outcomes, namely structural racism, and the systematic approach by which people have been excluded from resources, not only access to care, but we're talking about individuals not receiving the best care and the most optimal care that they can receive. That's health equity. How do we ensure that every living person has the opportunity to have the best health, where the healthiest choice is the easiest choice? To do that, we have to create healthier neighborhoods. To do that, we have to ensure that all resources are accessible to all people in New York. And so that's the conversation of health equity. And in doing that, in holding that space to have that conversation of health equity, we can truly have a fuller conversation about what has led to the disparities that we see, not only in cancer care, but also in all things that are leading to why people are not healthy. Right? And so a lot of the conversation that we have to have, first and foremost, before we can often bring up health outcomes, and this is what we do with our office and our staff, is that we have to talk about the historical context. The historical context for not only health, but we have to talk about the historical context that has led to why racism has even existed and why there are even discrimination and oppression that exists within certain neighborhoods. And so this has been a charge from Dr. Bassett. When she first came on in 2014, Dr. Bassett, after the murder of Eric Garner, sent out an email to all 6,600 employees of the New York City Department of Health, stating the exact thing that I've already mentioned, that New York City is one of the most segregated and unequal cities in New York City, and that inequities, health inequities, are unfair, avoidable, and unnecessary. What she was also saying to all 6,600 employees is that our charge is not only to do our job, but we have to be strategic and intentional about how we do our job. Having conversations and becoming an anti-racist organization must be paramount in what we do. It can no longer be just about collecting and compiling data. It can no longer be about designing programming. It can no longer be about strategies of doing outreach and engagement. We first must uncover how we make decisions, how we invest our dollars, how we allocate those dollars that ultimately are supposed to end up in the hands of the people in New York City. And so the first investment that Dr. Bassett had asked us to do was to think about and structure a way that we could become an anti-racist organization. And so we started to have those conversations as leadership. And one of the first things that she also did was making an intentional way of how leadership looked and try to evolve and ensure that leadership matched the city, demographics, and population. And so that means seeing not only a diversity in race and ethnicity, but also gender and sexual orientation, And so we have seen that involvement in leadership for the New York City Department of Health, and it has done wonders because the inclusiveness of conversation has changed. And the cabinets, the executive cabinet and senior cabinet of our commissioner, as well as the planning and the alignment across our agency. And so there are changes there. They can be measured and they could be tracked, and I think that they have made unique differences in the way that we have designed programs and made outreach and done work in certain neighborhoods. The other thing that we have started to do was started to think about, well, how do we normalize and operationalize a structure that will then allow us to have these conversations with all 6,600 employees and be able to measure how well we're doing. It is not an easy task to take as large of a city agency as we are one of the largest public health departments in the country, and to have this conversation around race and more specifically racism, and then ensure that there are ways in which you can connect this conversation to practice within the health department. That has been the large task for our health department. And I say that it is not only a large task, but it is a necessary task. And we have been challenging healthcare systems to think about how they incorporate that same task. One of the things that we have done around operationalizing this conversation is installed an exhibit called Undesign the Red Line. The red line phenomenon, although it no longer exists, we still see its vestiges in our health outcomes, in our schools, in our health systems. In the early 1900s, a government-sponsored homeowners loan corporation mapped out neighborhoods, Bed-Stuy, East Flatbush, East New York. When it was coded red, then there were certain loans or certain mortgage companies that would not even do business in those neighborhoods, thereby excluding certain resources and necessary assets to the residents who lived in those neighborhoods. The exact language that read on the Homeowners Loans Corporation is that these neighborhoods were full of black people, and they were full of people who was determined or designated not productive in society. It was a different word, just choose not to use that word. And so because that designation had happened in the early 1900s, not only did it exclude the certain types of loans that were given in that neighborhood, it also excluded what resources went to the hospitals, what resources went to the schools, what resources went to parks, and the list goes on. And so again, in this conversation of health equity, we're having this larger conversation around social context, because if we cannot provide safe environments where people can go to their parks, if we cannot provide safe environments where we have the highest quality of education for individuals, for all people, if we cannot provide awesome quality care for all people for institutions that are only a couple of miles from their residence, then that effectively indicates to people that my life doesn't matter. And so we're still seeing those vestiges because we're having conversations about inequities in neighborhoods like Bed-Stuy, like East Harlem, like Mott Haven, like Morrisania and Tremont, because these were the same neighborhoods when they created that map that were designated red. And so the association is super clear. We see the connection. We understand that that decision to designate these areas as red has led to the exclusion of certain resources and assets. And so we're undoing a lot of this work that has been happening for not just a decade, but we're talking about almost a century. And so these conversations that we are having, yes, it's normalizing partly, but it's also, we're trying to undo a lot of the past. The policies and the practices that have been set in place, and yes, although they are no longer active and effective, but again, we're still seeing the vestiges today. And that's the conversation that we often have to have, and wherever you go beyond New York City, that's the conversation you have to continue to have, because redlining was not just specific to New York City. We saw it in Baltimore, we saw it in Chicago, we saw it in Newark, we saw it in San Francisco, and the list goes on. And today in 2018, we're having conversations about gentrification, because quite frankly, this phenomenon is now leading to the displacement of people, and then not only the exclusion of people into neighborhoods, but the displacement of the existing people of their neighborhoods and off to other neighborhoods. And so what we're trying to do is, as gentrification is unfolding, is begin to track and identify where people are going. Because although we're seeing improvements in health outcomes in certain neighborhoods, it's not because we're doing a great job, right? It's more so because people are being displaced from their neighborhoods, and now we need to understand where those folks are going, because we still have work to do. So I just went through sort of our first approach. We did a lot of work around investing in our own agency. And what we hoped is that this will be a model for other institutions to begin to think about how they will build their own race to justice initiative. That's what we call it. We do trainings, we also do discussions, and we also look at our metrics across the agency. We have built action teams within our divisions, and so very analogous to the departments that you have here, to think about how in each division, what are activities that you can do to mutually reinforce understanding and mutually reinforce conversation around how structural racism has led to health disparities. And it has become quite effective. For instance, our emergency planning unit, these are the folks that are mostly responsible for responses like Ebola, responses to Zika, to Sandy, the storm, and to other emergency responses and crisis management issues that we have had. And what we have been able to map is that there are certain neighborhoods that do not have enough physicians, that if we were to ever have a pandemic flu again, if we ever have to another superstorm, then we would not be able to have enough clinicians to be able to respond and set up pod centers, what we call, which are distribution sites for antibiotics or whatever other health intervention that we need to get out to a lot of people. And so these are some of the inequities that we're starting to uncover. It's an intentional way for us to understand what has been inconsequential to how our planning and our programming has sort of laid out. And so this is the way now that we're beginning to restructure it. We're starting to see how we can make sure that we provide enough physicians, that God forbid that there's another large crisis in New York City, God bless you, that we can ensure that there are enough services for all people. So this conversation is larger than just, yes, surgical cancer care. And trying to give a global view, because what we have seen, one of the things that we're talking about in disparities is how we close the gap, right? How do we close this black and white gap? Because that has been the social groups that we've been looking at. And so one of the examples that we've been able to show is colon cancer screening, because there were intentional approaches that we did to ensure that all people had access to colon cancer screening. And so there were both policies and practices in working with healthcare systems. There was an intentional engagement strategy where we employed upon faith-based organizations, barbershops, beauty salons, and other stakeholders. But then also the messaging became quite simple. It became quite simple so that everyone would be able to understand how important it was for them to get their colon cancer screening. And so what we've been able to see since 2002 in New York City is that we have actually closed the gap around colon cancer screening in New York City, where actually black women actually have the highest rate of uptake as far as colon cancer screening for New York City. And so when your comparison group shows what's the best group that is actually utilizing a service, and you compare that to all other groups, then that's the way that you can begin to use an equity analysis. How do I close the gap? What do I need to do to bring everyone at least at the same level? Let that be my baseline, and then we can begin to improve everyone else. And so that's what we saw. If we focused on folks that were at the lower end, we actually saw a higher rate of colon cancer screening across New York City. where we're actually improving greater than national averages. And so that's the same way that we have taken this conversation around health equity and ensuring that we're always keeping in mind, so who is the most vulnerable? Let's start there. Because if we focus on the most vulnerable and the most oppressed, then we can improve upon everyone else in the city. Because then access to resources will be plenty enough that people will be able to take advantage of it. And so part of what we call that is our investment in key neighborhoods. And so my role as the Assistant Commissioner of Health for Brooklyn is really making sure that I focus in on places like Flatbush and Canarsie, Brownsville and East New York and Bedford-Stuyvesant, because again, if my focus is on who is the most vulnerable, then it is much easier to think about the other 18 community districts in Brooklyn. Much easier to have a conversation about where resources are and what are strategies that we can expand in New York City or in Brooklyn because we've been able to show progress and impact here in Brownsville or here in East Flatbush. And so that's been our approach, is to take it neighborhood by neighborhood. We've been really looking at work that we're doing in Brownsville, particularly around mental health and anti-violence work. Here in East Flatbush and Canarsie, we're working with University Hospital of Brooklyn around how we can improve severe maternal morbidity and maternal mortality, because the truth of the matter is that when you have Black women dying 12 times more likely to experience a childbirth complication than white women, then that clearly cannot exist in New York City, or at least that's not something that we want to see. And then when you begin to look at where are the hospitals that have some of the highest rates of severe maternal morbidity or maternal mortality, and this is where we come in when we think about coordinated care between medicine, OB, and even surgical division, because these are the things that we all have to begin to address together and collectively. There are reasons why we're seeing high rates of gestational diabetes and preeclampsia, high rates of hemorrhaging, and so we have to put our mind together to really figure out what we need to do to really address these root causes. And it's going to really take a collective strategy. One of the things that we've been, when we talk with healthcare systems, is really thinking about sort of a three-pronged strategy. One, and this conversation is going to hopefully continue to move this conversation forward, is take ownership of this thought of how do we address health equity and the social determinants of health. So not only in the context of risk injury and disease prevention, we have to think more upstream and really understand, well, what are the policies and practices within my own institution and that are affecting my patients that can ultimately bring better health outcomes for the patients that I serve in the population, right, and their families as well. So addressing health equity and social determinants of health, and what that means, how do we define social determinants of health? It has to be a part of our conversation. The second piece is using data to come up with creative strategies and policies that will advance health equity. And then specific in policies and then specific in health equity, because one, we already see how policies can do the opposite and exclude people, and so we want to think about inclusivity. But we also understand that policies create an opportunity for sustainability. And if we do not create policies, then things can move and shift and fluctuate very easily. And so even as health professionals, we always have to think about health equity policies that will benefit our patients. Who is best to be impacted by these policies? Who is most likely to be burdened by these policies? And am I making a difference? Those are the questions that we have to think about. And then the third strategy is always thinking about how we as institutions can be closer to the community and respond to their needs. That has to be paramount in what we're doing. We have to think about the structures that are in place, and as Dr. Salafu has mentioned, working with the Brooklyn Health Disparity Center, really always employing upon the community participatory research process, because we have to ensure that we are having conversations with communities and populations, particularly those who are most vulnerable, so that we are responding to their needs. And that has been something that we have been prioritizing, that as we are coming up with our budget, that as we are planning, that we are being intentional about including responses, including how people want to see funding spent. And so, I leave that charge to everyone here. And I know Dr. Lucchese has also mentioned to all of us is that as we walk out of these doors, think about the one thing that we can carry. And even for medical students, to think about how this conversation can continue in your small groups, to continue in your classrooms, and even in electives. It has been a great honor to work with a number of institutions across the city and thinking about creating small groups around advancing health equity, talking about medical bias, and bringing those conversations into your learning spaces so that as you move into the hospital and bedside, that you're bringing those same teaching points to your patients. And so I leave you with that. I thank you again for the invitation, and I hope everyone has a good rest of the day.
Thank you, Dr. Easterling. I think it is important to realize that even in this day and age, as Dr. Easterling pointed out, disparity is real. And we always have to ask ourselves, where do we come from, where are we, and where do we go? The complexities and the dark shadows of the past are what they are. We cannot make them undone. I think what we have to do is address, as Dr. Easterling said now, both from the healthcare provider perspective and the politician's perspective, these issues and make it better. Because the future has to be that all Americans have equal access to quality care. And we don't have that. When it comes to dying from cancer, it does not matter whether you're white, black, or any other color, whether you're male or female. We have to make sure that we do better. We are the richest nation on the planet, and we still afford 20 or 30% of our countrywomen not to have insurance coverage. It is unfortunately a disgrace, to say that in 2018, and we have to do better. Our next speaker is the Dean of the Office of Diversity, Education, and Research. It is my great honor to introduce Dr. Carla Booten-Foster, who actually is a graduate from Downstate. She received her MD here and went on to receive a master's of Science in Clinical Epidemiology at the Weill Graduate School of Medical Science of Cornell. She has many honors and awards received over the past few years. There's one that I want to point out because I think it really epitomizes what she has done. She was the first PI and director of the first NIH-funded Center of Excellence in Disparities Research and Community Engagement at Weill Cornell. As I said, she is the Dean of the Office of Diversity, Education, and Research. This is a department that does not exist at all schools in the country. There are actually not many that have that kind of an office, and I think it's extremely important to support the endeavors of our institution in that regard, because what we're trying to do is increase the number of minorities within the school and to make sure that people from minorities can flourish in the academic world as everyone else at this institution. So Dr. Booten-Foster will talk to us about advancing cancer health disparities research at SUNY Downstate. Dr. Booten-Foster.
So thank you so much for inviting me, Dr. Grusner, Dr. Schwartzman, Dr. Salafu. This is a very important discussion, and I'm really glad to have the opportunity to work with Dr. Easterling and to really continue the discussion around health disparities and health equity, but specifically about what we are doing here. So just to make sure. Okay, so before I start, I wanted to make sure that I acknowledge those who supported me in this talk. In particular is Mr. Wolf Lecossier, Director of Strategy and Community Campus Initiatives, and he helped me to compile data. Tina Ajay, Shamika Bowman, and Shanella Palmer from the Office of Diversity, Education, and Research. So the objectives of my talk are to provide a brief overview on the scope of racial and ethnic disparities in cancer. And I'm not going to belabor this point because I know you have experts in the field who are going to speak with you this afternoon. I will also like to provide some recommendations for advancing health disparities cancer research at SUNY Downstate and discuss some of the current programs that we have in place. So health disparities, we start with definitions. So according to Healthy People 2020, health disparities are defined as differences that are closely linked to economic, social, environmental disadvantage. And health disparities affect different groups, racial, ethnic groups based on religion, socioeconomic status, gender, age, and mental health, cognitive, sensory, physical ability, sexual orientation, identity, geographic location, and other characteristics that have been historically linked to discrimination or exclusion. And the take-home point from this slide is that cancer health disparities are multifactorial. They're not only genetics, they're economic, social, and environmental. And we often talk about health disparities being behavioral, but people do not choose to live unhealthy lives. And I think it's an important concept to really understand where do behaviors come from. They stem from the economic and social environmental support systems or lack of support systems that either promote or deter healthy behavior. So when we talk about behaviors, we have to make sure we talk about it in a global context of what drives behaviors, because we often focus on the individual and their behavior, and then we end up blaming the individual for behaviors that are sometimes out of their control. So I think that's an important concept for us to grasp. The NCI defines cancer disparities as adverse differences along the continuum from incidence through survivorship. So again, this talks about as adverse differences beyond race, ethnicity, beyond black and white. And a comprehensive cancer research program has to address questions pertaining to prevention and survivorship. Survival, who's surviving, how, and why. So this slide looks at SEER data, and basically, it basically shows what we know too often, unfortunately, that if you look at adjusted age and incident rates for cancers in general, there are exceptions, that blacks have higher incidence rates. But slide B shows that over 5 years, 5-year survival, the survival rates are lower. We know this, unfortunately. So these are data, these are basically facts about cancer disparities that we all know too well, that black men have higher rates of lung cancer, prostate cancer than white male counterparts. Black men and women have higher rates of colorectal cancer, a more aggressive conditions of multiple myeloma. Hispanic women, higher rates of cervical cancer. Native Americans, American Indians have higher rates of kidney cancer. And white women, while they have the higher incidence of breast cancer, but black women present with ER, PR, HER2 negative tumors, and therefore have poor prognosis. So as Dr. Easterling was talking about, that we really can't talk about disparities until we talk about some of the structural systems that were put in place. So disparities, it's not a new conversation. It really isn't. And I hope this isn't the first time that people are hearing about health disparities. That this is something, if we look back historically, we have over 150 years of policies and documentation talking about health disparities, whether it's called minority health disparities. These are differences that are largely based on race and ethnicity. So these are not new, this is not new data, right? If we go back 1865, Freedmen's Bureau set up after the Civil War around Reconstruction, and this was with the goal of helping freed slaves and poor whites after the Civil War with food, education, housing, and land. But this didn't go over too well because of Jim Crow laws, and there was still a lot of hostility, and the concept of giving anything to freed slaves was just not supported widely. So this didn't last long. In 1946, the Hill-Burton Act provided hospital facilities with money to develop new hospitals. But a lot of these hospitals were segregated. And in fact, it was felt that they said we would not discriminate. So what they did was created separate facilities for blacks. And as we know, separate is inherently unequal, right? In 1964, the Civil Rights Act, Title VI, banned discrimination by federal agencies that received state or federal funding. In 1985, Margaret Heckler, the then Secretary of Human Services, I believe it was under Reagan, for you history buffs out there, actually commissioned a report on minority health, right? So this is 1985, we had this document from the Secretary of Health and Human Services talking about health disparities. 1990, we had the development of the Office of Minority Health Research. The first time we hear about a national agenda to promote health, Healthy People 2000, and that focused primarily on decreasing mortality. In 2000, Healthy People 2010, there were still disparities and differences in outcomes. Healthy People 2010 focused more on quality of life and disparities. In 2002, the Institute of Medicine put out this, the report, Unequal Treatment, which documented racial and ethnic disparities in healthcare. So we're in 2002, right? In 85, Margaret Heckler put out this report. In 2002, IOM basically found the same things. Not much has changed. In 2010, we get the Patient Protection and Affordable Care Act, or the Affordable Care Act, which helped to expand healthcare. Opportunities for healthcare insurance for much of the population. In 2010, we had Healthy People 2020, which started talking about health equity. And then we had the election of 2016, and we might be going back, right? So this is not new. This is not new information, so we shouldn't be surprised about this. In fact, we should be downright angry, right? This ought to make you upset and really concerned about, as a nation, what are we doing that we're still having the same conversations about health disparities that we had in 1985 and before, right? So what's next? What's next? My slide. So in 2015, about 4 nationally known cancer centers came together to chart the future research for cancer health disparities research, which is the basis of my talk. The American Association for Cancer Research, American Cancer Society, American Society of Clinical Oncology, and the NCI. And they talked about some of the key things that we need to do as a nation and that our institutions can do to address health disparities through research. And this task force made several recommendations, focused on improving and better defining measurements, metrics, and tools, increasing representation in clinical trials, ensuring equity in healthcare delivery and resources, increasing opportunities for representation in clinical trials, improving community engagement, increasing diversity in biomedical research, and redesigning clinical research teams. So, better define measurements, metrics, and tools. This is basically standardizing determinants of disparities such as race, ethnicity, social demographic factors. You know, in order to do effective, rigorous, valid research that can be extrapolated and generalized, we have to be specific about what we're talking about. When we talk about race and ethnicity, we can't just focus on biological factors, right? Because then if you think about it, it's hard to change biology. We really have to be honest with ourselves and say what underlies race. Right? Race is not a biological construct, right? In fact, Dr. Patu will tell you that much of the genetic information that we share, about 85% is similar, and there's very few, there's probably like 10 or 15% that can really isolate what is true race, and it's based on whether it's melanin or other characteristics. But when we talk about race, we have to stop talking about it as if this is a biological factor when it isn't. Race is really a construct that's based on social, political environment. In fact, the concept of even Hispanic and Latino was something that Congress did to better identify people as their ethnic group. So when we talk about race as a social construct, then we can begin to look at the underlying factors that contribute to disparities in race. So we have to go beyond race as just a cell. It is not. Self-reported measures. It's important for us to understand how people identify themselves. Because if you identify yourself as Black, Latino, Asian American, then you may be more likely to assimilate with a certain group, or maybe your social networks may be similar. So we can't look at someone and say that someone is Black or white. There's so much heterogeneity within the race itself. When we talk about Latinos, not all Latinos it's not a homogeneous group. Are we talking about Latinos from Honduras? Are we talking about Latinos from Mexico? Are we talking about Latinos from Panama, from Costa Rica? So we have to be really specific and use the same language. Race, ethnicity, ancestry, nativity, migration. SUNY Downstate has a unique opportunity to really advance the research on nativity and migration. And how does that impact health, incidence, prevention, survivorship? There's no other institution that I believe that can do this. You know, we have a wealth, we often talk about our patient as those patients, but it's because of these patients that we are who we are. We have the tremendous opportunity and the privilege to care for patients from West Africa to Haiti. I'm from Haiti, by the way. Is anyone else from Haiti? No? Okay. So we have a tremendous opportunity to care for a diverse population of patients. We're working with SUNY Albany and other institutions in upstate New York to look at the differences in rural or urban. How does that impact health disparities? Environmental exposures, where people live, access to screening, healthy food choices, safe places to exercise, neighborhood. You know, there's data that describe the neighborhood, what you think of your neighborhood, cohesion, noise, pollution, and how that impacts health disparities also through stress mechanisms. In terms of defining measurements, metrics, and tools, we have to be very specific and strategic about what we're asking. You know, your results are only as good as the question that you ask and the instrument that you use to measure it, right? So when we talk about measurements and tools, we have to make sure that the instruments that we're designing and developing to inquire about health status and outcomes, that they're really linguistically and culturally tailored to the population that we're working with. For instance, we often use, I believe it's Konofsky scales or scales to determine whether or not someone's going to be included in clinical trials. And a lot of these performance measures ask about ability, right? Are you able to walk? Are you able to climb? That excludes people who are otherwise functionally independent, but they may be in a wheelchair because they cannot walk or climb, so they're excluded from clinical trials. Right? So we have to make sure in designing clinical trials that we're not inadvertently excluding the very people that we want to help. We have to look at issues as language fluency and numeracy, which is different from fluency because it says that your ability to assimilate numbers and to use it in a way that will help you to make your healthy decisions. So when we say you have a 10% risk versus half of the population, what does that mean? What does that mean? So we throw these numbers out when we're trying to recruit our patients and populations, but we have to make sure that we're really asking the questions that we want. Otherwise, we're going to ask the wrong questions and get the wrong answers and disseminate it widely. And people are going to make wrong decisions for our patients, right? Health literacy is very important, and psychometric testing of our tools to make sure that they're valid and reliable. So increase opportunities for participation in clinical trials. So there is a number of clinical trials and initiatives that are out there, from the Cancer Genome Atlas, precision medicine, which talks about the right treatment for the right patient at the right time, Vice President Biden's Cancer Moonshot, which tries to accelerate cancer collaborations for discoveries, international studies. I have the opportunity to work with some colleagues in Nigeria who are finding the same thing, that young Nigerian women are presenting with more aggressive breast cancer that are not responsive to hormone therapy that we would have. This is a tremendous opportunity, again, to look at migration and nativity. You know, what's happening to our populations in other countries here? You know, when our patients are coming from the Caribbean or Africa, what does it mean? What does that do to health disparities? How do the health disparities look from a global perspective? Again, SUNY Downstate is in a unique position to really drive this type of research. So clinical trial participation. So this review looked at clinical trials that were done over a 10-year span, right? And the statistics are that while racial and ethnic minorities bear the greatest cancer burden in the US, we're still underrepresented in clinical trials, where over 80% are still white, predominantly white men, 6% are African American, 3% Asian American, 2% Hispanic, and less than 1% Native Americans. Right? And the NIH, actually, I believe it was in 1994, that said that you had to include racial ethnic minorities and women in your clinical trials. Right? So we have to be very aware and cognizant of who's in our clinical trials and how are we making decisions about a population that's not included in our trials. So that's really important. So how do we do that? We have to really redesign the clinical trial environment, make sure that there's representation in the team, the investigators, the community outreach workers, your patient navigators, the data collectors. We have to reduce barriers, right? We have to make it easy for people to want to participate in clinical trials, making the information available. Yes, we have clinicaltrials.gov, but not everyone looks at clinicaltrials.gov. And in fact, if you look at the people who are accessing clinicaltrials.gov, these are the individuals who may have more means to get health information. So we have to make it easier for people to access data. We have to look at the cost. There shouldn't be a cost to participating in a clinical trial, and that cost can be transportation, right? If you have to travel far to get to an institution to participate in a clinical trial, then it's likely that you won't be able to. Clinical trials, if we're doing clinical trials in a population that's younger, maybe of childbearing age, look at the opportunity to afford child care, providing incentives to patients. Because when you think about patients participating in clinical trial, that individual patient may not benefit. In fact, in our IRBs, we write that you may not benefit from this, right? So what are they getting? What are some of the incentives for participating in clinical trials? And honestly, as a patient, it has to be above and beyond contributing to science, right? So we have to think about engaging them, making them be a part of the team. We also have to look at respect for autonomy, intellectual property, regulatory compliance, as we try to create biobanks. Because all of the Cancer Genome Atlas, the Cancer Moonshot Project, Precision Medicine, they're all based on biobanks, right? And our ability to collect data in the proper way and to disseminate the information from that data. So everyone knows who this is? Henrietta Lacks, right? So we know a lot about her from the book that was written by Rebecca Scoot about her trials that she went through when she went to an academic institution for treatment for cervical cancer, and her cells have been used for a variety of conditions, which is good, This is really important. We've learned a lot. A lot of people have survived because of that, because of her as a result of Miss Lacks. However, if you read the book, you read the story about her family. You know, members of her family were incarcerated. They lived in basically abject poverty and never knew about this. Never knew about this. And truth be told, while science was advanced, people made a lot of money off of these cells, right? The Havasupai tribe versus Arizona Board of Regents. Has anyone heard about this? Yeah? Okay. So I believe it was in the 1990s. Members of the tribe wanted to find out about diabetes. Why were the rates of diabetes so high in their community? So they went to the University of Arizona, and they participated in a research study to help to address diabetes. Out of this study came information about mental illness, schizophrenia, geographic origins, nativity, that really contradicted a lot of the narratives and stories that helped to keep the community together. Basically, it said some of you were not born here. Right? Mental health. You're getting information about mental health, and you didn't participate in a study on mental health. So this information was really contradictory to what they expected. So the university spent over approximately $2 million fighting lawsuits and paid over $700,000 to members of this tribe. So it's really important to have respect for community autonomy, to recognize community assets, to leverage community resources, to build community capacity. And if we're talking about advancing health disparities research as a premier academic medical center that is located in a wonderful community, we're an academic medical center in a community, not a community center, right, Dr. Salafu, right? As a premier academic medical center, we have the opportunity to work with a wonderful community. We really have to look at the community differently. What do you see when you see this slide? Huh? What do you see? Graffiti. What else? What about the two individuals? Are there any differences? Well, I'm just going to go ahead because we don't have that much time. Basically, yes, you can see graffiti. You can see buildings that may not be in the best position. You can see a male who's overweight and another young man who's posing. But there's also the opportunity to address male health, minority male health. There's the opportunity to leverage the arts, right? To create murals on buildings that promote health. The opportunity to create intergenerational dialogue, right? So your solutions to disparity will be based on what you see. What about this? Kid's not wearing a helmet, right? What else? He's doing a wheelie, right? Right. So, sorry? The trauma, yes, right? But, so then opportunity for intervention, for healthy options for physical activity. Apparently this young man wants to be physically active, right? So let's make it easier, to avoid trauma, right? What about this? What do you see? Right. But entrepreneurship, right? And in the back, there's the restaurant, right? But this is an opportunity to educate, to work with the community vendors and say, hey, look, I know you have to make a living. How about selling these, right? Entrepreneurship, small business ventures right here, right? And here, what do you see here? Okay, so fried chicken. The president's fried chicken, right? I didn't know the president had right? You see the train, but there's also, I don't know if this works. No. There are pharmacies, right? Each of these pictures, if you look closely, has a pharmacy, right? So if you look closely, this is an opportunity for intervention, working with local pharmacists. If you walk up and down Clarkson Avenue, you see a lot of pharmacies, Flatbush rather, you see a lot of pharmacies. So again, your interventions are really as good as what you see. Community-based participatory research is an approach. It's not a research method. It's an approach that allows us to engage community in equitable research. And community participatory research really engages community from the inception of the research project. Much of what we do is not community-based participatory research. It's community-engaged research, where we come up with a research project, and then we say, let's go to the community to see what they say. Let's go to the community to help us recruit participants. That's not community-based participatory research. And this is important, not in, like, when we talk about it in this setting, but when you're applying for research grants, if you say you're doing community-based participatory research study, an NIH study section will shut you down, and basically you will be triaged because you're saying you're doing community-based participatory research, but it's obvious that the research idea came from the investigator. So we have to, in order to advance cancer health disparities research, we have to promote diversity in biomedical research, right? The number of students of racial and ethnic backgrounds still has remained the same, where the majority of students are about 60% white students, about 20% Asian students, and the racial and ethnic minorities are less than 11%. But at SUNY Downstate, I'm proud to say that we are about 23%. In fact, we have 48 racial and ethnic minority students in our class. And that's not by accident. This is not by accident. This is really creating an opportunity for some of the most talented and diverse students to want to come to SUNY Downstate. The disparities are still, there's also a gap in full-time faculty and the number of chairs and the number of women of color and women in general who are department chairs. And this is important because your chairs and your deans really drive the research agenda. It's really important that if your chair and your dean are not supportive of research and that will not provide opportunity for faculty to develop and train in research, if your dean is not supportive of research, this will not happen. So we're really fortunate at SUNY Downstate that we have chairs and deans who are really invested in advancing research. So we have to fix the pipeline. This slide is from Dr. Juanita Merchant, who's a gastroenterologist and basic scientist, that we have to look at where's the leak in the pipeline. Is it mentorship? Is it bias? Is it unconscious bias? You know, what's happening that we have to increase the reservoir, but we also have to fix the leaks? So in order to advance health disparities research in cancer at SUNY Downstate, we have to move out of our silos, from silos to monodisciplinary to not only multidisciplinary, because we can say we're working in a multidisciplinary team. You know, you have two people, you have a basic scientist and a clinician, they're in the same room, not necessarily talking together, but it's a multidisciplinary team, right? Interdisciplinary people start to talk to each other, but they still go back to their own silos. transdisciplinary is really an interesting concept that it says our discussions will create a new language. Our discussions will lead to a new model. Our discussion will create a new concept that combines both disciplines and blends them in the way that you really can't separate them. And then we're moving together to address health disparities. So research really has to move towards transdisciplinary research. And this is important because I know you've all heard of translational research. And I think it was in 2003 when NIH put out the NIH roadmap and the blueprint and talks about translational research as a way to redesign the research enterprise, to shorten the gap between basic science and community outcomes, which traditionally has been documented as taking about 17 years. And during that time, what happens? People die and health disparities continue. So there's this desire to shorten the gap, right? And the translational research paradigm was the promise of that was that we would bring people together, basic scientists and clinicians, to talk about the genetic, biological, social, political, and environmental concepts. And this is important for advancing health disparities research, because if we understand some of the psychosocial stress and early life adversities that can perhaps modulate gene expression and lead to susceptibility or vulnerability to certain diseases, we have to connect our basic scientists with our community so that discoveries in the lab are being informed by what they see in the community. And this will also help to shorten the time lag for research to reach practical applications. So at SUNY Downstate, we're really fortunate, again, 2.6 million people. We have the opportunities to provide care for communities in Flatbush, East Flatbush, Bedford-Stuy, Crown Heights, Brownsville, and East New York. This data comes from Wolf Lacoste. Here. And basically it shows what do we see at UHB versus Brooklyn as a whole in New York City residents. And these cancer, and I believe a lot of these cancers you're going to talk about, and these are discharges, right? So the colorectal, prostate, breast, lung, liver, pancreas, esophageal, intestinal cancers. These are discharges. I believe it was 2016. If we look here, the majority of patients that we see relative to Brooklyn as a whole in New York City are people of color, right? 91% of our discharges or UHB are African American. There's also Latino here, but I'm sorry, it is represented in here also, right? But the majority of patients that we see are Black, which again says to me that we have a tremendous opportunity, right? We have a tremendous opportunity, if not a duty, to address health disparities in our community. If you are doing research at SUNY Downstate, if you're recruiting patients from our clinics, by default, you are doing minority health research. So this is really important. If you look at this slide, 70% of our discharges were female. A lot of it may also be due to gynecologic care and OBGYN and birth, but it also shows that we can do better with recruiting men in our practices, right? So this slide shows basically communities that we see, and again, I highlighted Brownsville that Dr. Eastland talked about. So these slides basically tell us the population we need to address and recruit and that we have an opportunity to serve. This slide basically looks at social determinants of health in terms of race, ethnicity, employment, insurance, smoking status, obesity, diabetes, violence, incarceration, and life expectancy between the communities we serve and more affluent communities like Park Slope. Again, we can't talk about cancer health disparities and addressing research without understanding the social context in which our community members live. Transport. So what are we doing at SUNY Downstate? Transport. In 2007, SUNY Downstate received an NIMHD, National Institutes of Minority Health Endowment, to support a program known as Transport, Translational Program of Health Disparities Research Training. The PIs are Dr. Salafu, Dr. Patu, and Dr. Riley. And this basically provides an infrastructure. It's a $10 million grant to be $2 million installments over 5 years, and it's like any endowment, you're waiting it to grow. So no, Dr. Salafu does not have $10 million to give. So it's an endowment, and it will grow, and it will continue to grow as long as it's invested in, and it does well. So what does this do? This supports research training. Unfortunately, it does not support research studies like clinical trials, and it doesn't support necessarily creating research programs unless part of the program is developing the capital, the human capital to implement these programs. So some of the things that we're doing are training undergraduate students from schools, Medgar Evers, Brooklyn College, SUNY Albany, to come down here and spend the summer with us. So this past summer, we've had some students train with us, with Dr. Michelle Patu, with Dr. Michael Reinhardt. Some students trained with me. Some students worked in Reno with, in the nephrology unit. So it's training undergraduate students. We're also training junior faculty. So I hope that you saw the Diversity Fellowship announcement that went out, and it's to train junior faculty in cutting-edge health disparities and translational research. Yep. The Brooklyn Health Disparities, Dr. Easterlin talked about it. The PIs are Dr. Salafu and Dr. Fraser. It's a consortium of sorts with SUNY Downstate, the Arthur Ashe Institute, and Brooklyn Borough President's Office. The Department of Health is also very much engaged, and it's an interdisciplinary group that's working towards a transdisciplinary approach to health disparities research. So we have representatives, Dr. Straker and Makia, Dr. Stewart from the graduate school, Dr. Wilson from public health, Dr. Joseph from public health. We also have Dr. Shirley Gerard from nursing, who works with us, and Dr. Margaret Kaplan from church. So it's interprofessional group of scientists coming together to address health disparities. The Arthur Ashe Institute, that's another opportunity to advance health disparities research. It's to look at novel ways of introducing clinical trials. Dr. Tracy Wilson has gone to barbershops to talk about HIV among heterosexual men. And so we have an opportunity to talk about colon cancer screening, signs and symptoms of prostate cancer. There's a lot of discussion about to screen or not to screen, but the discussions need to, all of the societies say you have to have this discussion with your providers. So patients are not even having this discussion, so this is a tremendous opportunity to do so. The Arthur Ashe Institute, we've participated in programs in salons and barbershops and faith-based organizations also. There's also an opportunity to be more inclusive in our research. So we have the STAR Clinic. We have a transgender health clinic. But we don't talk about health disparities when it comes to the LGBTQ population, who because of, again, discrimination and access, right? Behaviors cannot be talked about without, out of the context of access and discrimination. That may contribute to more smoking, in some of our LGBTQ patients, which leads to lung cancer, HPV-associated cancers, breast cancer screening, and cervical cancer screening. So we don't talk about health disparities in the LGBTQ population. We also don't talk about disparities when it comes to patients living with disabilities. Marilyn Saviola directs the Women's Health Program, Incidence, Independence Care System, and basically she talks about the barriers that women physical disabilities have to getting breast cancer screening, right? So we have to be more inclusive in our approach. So again, remember to advance the cancer research paradigm, it has to be from prevention to survivorship. So we have to talk about protective factors, do studies on protective factors, social support, coping mechanisms, caregiver burden, right? In a community that may be bereft of social resources and caregiving has a different dimension, or palliative care may not mean the same, we have to look at what impact does this have on caregivers' mental health and maintaining functional independence. So our approach to research in order to advance health disparities research is really to position SUNY Downstate as the premier academic health disparities research institution. Right? We have to think of research that's transdisciplinary, translational, and transformative, that looks at some of the genetic polymorphisms, evolutionary selection that impacts chronic inflammation and obesity. We have to look at biomarkers, a variety of biomarkers, differences in tumor burden in the environment, response to immune response. I had to put that there for you, Dr. Roman, the immune response, differences in cancer-initiating cells, lifestyle risk behaviors, and all of these factors that lead, and access also. So our approach and conceptualization of research has to be global. And I do believe, this is my last slide. I do believe that, again, at SUNY Downstate, our mission should be, what we do should be mission-driven and community-informed. And our mission should really be informed by the community that we serve, right? We have a tremendous opportunity a unique opportunity, if not the privilege, to really advance cancer research in a way that no one else can talk about. I recently had the opportunity to take my son to Oxford, yay, Carla, who's spending a year at Oxford, and the city is just unbelievable. And I was walking around at the building, and I told my son, I said, you know, in a couple of years, we're gonna go to Oxford, and they're gonna say, welcome to Oxford, the SUNY Downstate of England, right? We have an opportunity to do that, and it starts here. So thank you so much for inviting me to be here, and I look forward to the work that this group is gonna do.
Thank you, Carla, for a wonderful talk. Thank you. Thank you, Dr. Lukisi, for coming. We are on time, just to reorient your minds. We are on time. We're actually 15 minutes ahead, so just to let you know that. Our next speaker is Dr. Julianne Shapiro. She's currently the Chief of Hematology and Oncology at SUNY Downstate. She is very dynamic, as you would see very soon. She's brought a lot of programming to SUNY Downstate in terms of cancer care, organizing the communities, and making sure that we have the resources to treat our patients. It's a great pleasure to welcome Dr. Shapiro to this symposium, and thank you for what you're doing for SUNY Downstate.
Thank you so much. Thank you for the warm introduction. I'm waiting for my slides. So I'm going to talk today about the access to cancer care at SUNY Downstate and how our Cancer Institute Navigation Project informed us as to what we need to do to help our patients better. Okay, so when we talk about cancer care at SUNY Downstate, first we have to start with the Tumor Registry. And we have to understand what type of patients we see, what is their age group, and then with that information, we can inform how to better serve them. So if you look at Tumor Registry at SUNY Downstate, what is reported at New York State Tumor Registry, we see that the majority of our cancer patients are younger than 65 years of age, which is 72%. And those younger than 54 years of age are 37%. So our cancer patient population is 15 years to 20 years younger than the general cancer population in the United States. So we have to be mindful of that. These patients that are younger than 65 usually are employed, and they also have other family responsibilities, as any one of us in this room will attest to. If we look at what's happening in the young patient population group in the United States, we can see that a very preventable malignancy, colorectal cancer, is on the rise. In fact, colorectal cancer incidence in young population, remember this number, it's 30 per 100,000 people in the United States. And I will show you our numbers, and you will understand the glaring disparity. So we have to understand our numbers in terms of, are these young patients, or are these the common variety patients seen in the United States? And also rising are lung and bronchus, which is about 28%, lymphoma and leukemia, and thyroid cancer. Mortality in young patients is far greater than the general population. Young people die of breast cancer, they die of colorectal cancer and lung cancer in far more numbers and proportions than those older than 65. And I'm going to focus on the colorectal cancer because this is the most common cancer in our patient population on our discharges, and is the most preventable. In fact, more than 20 years ago, we found out that colonoscopy or colon cancer screening method decreased colon cancer mortality, so disease-specific mortality, by 30%. This is an information that's been there for more than 2 decades. So this is our colorectal cancer survival. So the survival in 5-year survival has increased from 1977, and when it was about half, to 66%. However, the survival is different if you look at the national white people population, which is 66%, versus black. So black survival from colorectal cancer lags behind. However, remember, our patient population are 2 decades younger than what's reported. Now look at the incidence in our central Brooklyn and think about what I said before. So the prostate, this is incidence per 100,000 Brooklynites, central Brooklyn patients. We have colorectal cancer at 55. The national for this age group is 30. It's double, okay? And when you look at the survival, if you look at the survival is only 47% of those diagnosed in central Brooklyn survive their colorectal cancer, not 66%, right? So if we put everything in context, we understand that we have a crisis in our hands. So we need to put this information in a way that it can be understood by the community. And our community, I'll show you from results from our navigation pathway, our community wants this information. They don't get it, but they want it. They want it. They do not receive this information from us, the providers. So we have a large guilt in the community health, in the community we serve. So we have to transmit this information to people who want it, to those who understand it, and to those who don't have it. And I will show you data, concrete data, that our patients, not only they want it, but they also understand this information. And this is a break with what's published out there. And also, they don't have it because we don't have centers to transmit this information to those patients. All right, so let's look at our methods of studying this problem. So we used validated questionnaires that were available to us for free. So we called the principal investigators of those individuals who validated these questionnaires, and we got permission to use them. So we used the autonomy and desire for autonomy and desire for information, and we use these 4 validated questions, and these are our results. So it turns out that our cancer patients in a group of 157 individuals consecutively coming to get their treatments at Downstate, majority of them black, as you saw in Dr. Butin Foster slides, a lot of our patients, more than 90%, want medical information. They want it. However, when it comes to decision making, they put their faith into our hands. And here is what we have to take home. These people trust us. We have to serve them well because they put their trust and their lives in our hands. So this is unlike anything else that's published out there, and I'll tell you more about this story. So the p-value was 7 times 10 at minus 17. Any statistician will salivate over this p-value. Who needs this information? So who understands this information? So you know from the literature published in the outside that minorities are regarded as they don't understand what you're telling them. They have health literacy problems. They don't fill out their prescription because they don't know. They cannot read written material. We found this in our patient population that is quite different. When we did the brief report and the single item literacy screening, and these are validated tools to assess literacy, we found out that our patients don't need help for others to read the medical information we give them or to understand what we tell them. In fact, the majority of them, this is the p-value, look at the number, how many zeros, the majority of them understand what you tell them if you just took the time to sit and explain it to them. So this was the part that when we put together the paper, 2 different journals rejected it. They said this contradicts what available information is out there. And it's time for us to contradict it time and again until it becomes a known fact. So these are the disease information centers in downtown Brooklyn. You don't have to be a statistician to see the number of yellow points there. And Flatlands, Canarsie, and Brownsville. Brownsville is the the desert area. Maybe East New York you have a little bit, but the population here at Flatlands that we serve have nothing, have even no centers where they can get disease information. And this is by Medicaid support. Again, we have much more Medicaid beneficiary, and it's inversely proportional to the number of centers of disease information. All right, so what do we need to do to implement this? So now we know that knowledge is not disseminated to those who want to know it, those who understand it, and also those who do not have it. So this is a system problem. It's not the patient's fault. It's not that they're non-compliant. They don't know because we do not bother to translate medical knowledge that we acquired more than 20 years ago into what they need to do. We're not capable of disseminating and implementing best practices. So the priority for us in colorectal cancer, which is a highly preventable malignancy, and we would prevent half of the deaths that occur right now, is to go to areas of lower screening, higher incidence, and high mortality. So this is the Brooklyn screening for colorectal cancer as compared to New York State and nationwide. So we are still at 47%. We're under screening for a very preventable disease, and that's not the patient's fault. It's very easy to screen, and you don't have to do colonoscopy on everybody because our patients have jobs, but they're younger than average colorectal cancer patients out there. They have jobs, they have families, they have other priorities. You can use a guaiac test or something simple. This is $13. You buy it at Walgreens, and you know that if the guaiac test is positive or not, they will prompt the patient to go and seek additional care. But most importantly, these patients should know about this. There are information that they should have. So this is the rates again in whites, and these whites are 20 years older than our patients. Their rate is 46 per 100,000. Our rates in young black people is 58 per 100,000, not 30, 58. For those of you who are not from Brooklyn, I'm not from Brooklyn, I always use this map to orient myself. So we serve the population in Flatbush, East Flatbush, Canarsie, Brownsville, Crown Heights, and Flatlands. Also we serve East New York. So this is the catchment area where most of our business in cancer comes from. These are the hospitals that serve those patient populations. So obviously it's the University Hospital, Brookdale, Kings County. This is and Kingsbrook Jewish. They serve the largest burden of this central and East Brooklyn population. Again, this is the incidence of colorectal cancer in Brownsville. I showed you where Brownsville is, where there is no center of informing patients, right? So the incidence in young patients is twice the national average for young, twice. Let's go on. So Brownsville, right here. Then this is the incidence of colorectal cancer in East New York. This is an area where we draw a lot of colorectal cancer patients, 63 per 100,000. 1 second, just want to show you again East New York, right here. And this is Crown Heights. We serve a smattering of population from Crown Heights. The incidence, again, very high, 60 per 100,000. Crown Heights, probably South Crown Heights is what we serve, and a little bit on the East Crown Heights towards Brownsville. So if you look at, this is the discharges that are reported to the New York Tumor Registry. Majority of our discharges come from East Flatbush, South Crown Heights, Brownsville, East New York, Canarsie, and Bushwick. Again, the age group, I don't have to belabor this. We serve young patient population, which are much younger than the national average. And what we see here, this is a slide that we all have to take in our minds home, is that 75% of our cancer discharges are female. Not because we don't see men with cancer. Actually, we see equal numbers of men and female. But men in our community, they have 2 jobs. They take care of family. They sometimes work and send some money back home where they immigrated from. So they really do not have time to come to the doctor. Therefore, when they come, they die in the hospital. Their first admission for cancer is their last. Deaths are not reported at cancer registry. What you report to cancer registry is discharged alive. So this is heartbreaking right here. So I hope that I covered what is the knowledge that we need to transmit, why do we need to do that, to whom, and where and when we need to intervene. This knowledge is not routinely translated into health practice, and I don't know why. Because it's lack of information, it's lack of screening, or providers who are interested in colonoscopy because it's high value RVUs and it's good for the hospital. We don't look at other things, and obviously there is a lack of information that we transmit and disseminate to our communities regarding the preventability of this disease and the lethality of the disease if we don't do anything about it. How we can change the status quo? Obviously, we have to go to the multi-step approach in every system that's broken. I'm not going to belabor. These are things that are done at corporation level in any corporation when you try to fix a problem. But I will focus on this one, which is serious psychological distress. So when patients are diagnosed with cancer, they're like devastated, right? So we are obliged, the cancer doctors must do a distress thermometer on everybody diagnosed with cancer because that's part of their clinical care. So when we when we look at the distress and look at the income, which is on the lower end, and the distress, which is dark red, is a lot of distress, and you can see a lot of distress where the Eastern European, like myself, come from, right? Sheepshead Bay and Coney Island, Oy Vey, Sheepshead Bay, a lot of distress reported there, ladies and gentlemen. But then when you look at the patients that we serve, they're happy. They're not distressed. So when I saw these charts, I said, how am I gonna explain this now? What makes the difference between these immigrants here and these ones here? So I probed further. So I looked at the ways people cope. So there are validated questionnaires such as RCOPE in which they look at ways people cope with distress and stressful events. And it turns out that our patient population have positive religious and community feelings. So whatever happened to them, they accept it and work with what they have. They do not blame others. They do not, whine, why me? They actually say, okay, I have this, I'm gonna do A, B, C, D. So it's that coping mechanism that utilizes the community and their religious faith that is extremely important for our patients. And also, even more important, is their grit. There is a questionnaire that assesses patients' grit and resilience in front of distress. And it turns out that our patients, look at the difference. Majority of our patients, 95%, have very strong grit. In other words, they're capable to cope with whatever life throws at them. And this is an honor for me to take care of these patients. My husband practiced in a different area, in a different neighborhood, and he envies me for the patients I take care of. It's really an honor to take care of these people. So how can we change the status quo? So multi-step approach, community outreach seminars, pharmacy initiative, church-based initiative, better provider education. So we have to look in the mirror before we blame our patients for non-compliance. Have I given that patient all the tools and all the information he or she needs to succeed in this cancer care? Find creative strategy and then transform this strategy into specific activities that are needed. So what we need procedures, we need leadership, we need resources and coaching, education and training of our patients and community. So not only we have to look at what intervention we propose, but also the population uptake of that screening method and understand why one screening method is better than the other. It doesn't matter what cancer screening you're talking about. So once we define those palatable screening methods that are populational based, I think we can move the needle away from high mortality and high incidence. And I think we have to create also a way to sustain the methods and the pathways we create. So with this, I'm gonna end my presentation and take any questions if you have any. Thank you.
Thank you, Dr. Shapiro. I think it's really important to realize how different our community and Central Brooklyn really is from the rest, not only of the city and the state, but also of the entire country. And I think both Dr. Button Foster and Dr. Shapiro have made that clear. I have asked one of our faculty, Dr. Warren Whitman, to talk at this conference. Dr. Whitman received his MD from Yale and did his residency there as well as his fellowship in cardiovascular. But Dr. Whitman has a very distinguished career as a surgeon educator. And I must say, he has, since I have been here, an extremely helpful to the department with regards to his contributions with regards to the grand rounds that we have, to M&M conference, to mock orals and so forth. He has been involved in surgical education at many different institutions, including Columbia. He is an assistant dean here for surgical education and for education at SUNY Downstate, and he is going to talk to us about healthcare disparities and surgical education of medical students and residents. And I cannot overemphasize the role in that, because I think one of the areas that will distinguish you again from your peers as you go out to do either residencies or to become faculty and attendings is to understand what disparities are about and how to address all these issues. So thank you very much, Dr. Whitman, for talking to us today.
Good morning. And, well, I just familiarized myself with the beeper here. If anyone would like to stand up and relieve ischial pressure sores, take a second to shift and whatever, because we've been sitting a long time. I know I sneaked out, so I'm not going to begin just right away. I'm just going to familiarize myself. Well, first of all, thank you for including me, and as a participant in this, you always wonder what the other people are going to say that have covered what you're going to say. And fortunately, there's relatively little overlap. So the folks in the back, pay attention. There may be something new coming. Let's start by talking first about the whole issue of disparities. I know we've been given a little bit of background on this, but disparities really were not very much addressed in our country. Even though we had a National Academy of Sciences, they didn't even include medicine in the sciences until 1970. The Academy of Sciences was established in 1865. Didn't include medicine, not until the 1970s. Once it was established, very quickly, as others have pointed out, they recognized that there were racial and ethnic minority groups who received lower quality healthcare services, fewer routine medical procedures, less appropriate medication, they studied cardiac medications, fewer advanced cardiac procedures, fewer renal transplants, and even less intensive care once hospitalized. And that's even when corrected for factors such as insurance status, income, age, and comorbid conditions. Got a chart here that looks at the quality of care, and it's good to be high. And non-minorities generally get better quality of care. And that's a difference. But there's something that's more subtle. What's the semantic between a difference and a disparity? A difference can be due to patient preferences. A difference can be due to very appropriate reasons. And if that difference is appropriate, it's not a disparity. A disparity comes in when the systems in which we operate, healthcare system, legal and regulatory climate, are unequal. Worse yet, when discrimination, bias, stereotyping, and we'll come back to this repeatedly, uncertainty play a role. That's when we start seeing disparity. And what did the Institute of Medicine produce? A document, 432 pages, published about 15 years ago, in which we got a title of Unequal Treatment, Confronting Racial and Ethnic Disparities in Care. So it's been out there for 15 years. And what they pointed out, that while some studies show that disparities, not differences, disparities, tend to lessen or even disappear when socioeconomic factors are controlled, the majority of studies find that these racial and ethnic disparities remain even after socioeconomic differences and access has been addressed. So disparities persist. That should be troubling. So we're all enlightened, we're enlightened healthcare providers, would like to think that we're free of racial and ethnic discrimination, but there's ample evidence to the contrary, given the data of unexplained differences in outcomes. And I think we had a very, very good background by Dr. Easterly when he mentioned redlining. Not many people know, but New York in the 1700s and the 1800s, there were no black neighborhoods, there were no white neighborhoods. Discrimination came as a result of the redlining that Dr. Easterly pointed out. Redlining led to the discrimination and the differences in housing. So that's where we live. We're a very segregated community. We talk about the South. Yeah, the South has its problems. The North does too. It's not only housing, it's where we work. Vast discrimination. So we start with an unequal playing field, and going back to this earlier slide, much is made of this aspect here, that, well, maybe racial minorities have different preferences. And I think that Dr. Shapiro pointed out that some of those preferences actually are very favorable. But let's look at the stereotypic answer that we get. Stereotypic answer is, black people don't trust us. Remember the Tuskegee study. Now, for those of you who were born a little after I was, you know, like almost all of you, the Tuskegee study was a study developed by the U.S. government, continued by the U.S. government, began in the 1930s, and it enrolled black people who were victims of syphilis, withheld any treatment from them, and studied the natural cause of the disease. Now, we in America were very proud of how we responded to the horrors of the Holocaust, and we had the Nuremberg trials and held accountable those terrible Nazis. Terrible as they were, our own government and our own physicians, while not overtly causing disease, were not treating it when penicillin became available. A terrible, unethical study. In fact, the people were misled and were even told they were getting appropriate care. Now, you know that this study is outdated because, look, they had bumpers on the cars in those days. Can't find them anymore. The shibboleth, the belief is, why would minorities be prone to refuse care? And the Tuskegee study is constantly mentioned for that. But I think Dr. Shapiro told us that's not that prevalent these days. And studies now show that refusal of care is only a small portion. And I'm very interested in her studies because that's not well known. There's that constant belief that the minorities don't trust the majority, the white, the Asians, who are taking care of them. Then there's another argument, and that argument is that, well, the white people are getting more care, but it's overuse. They're just overusing the system, and the blacks are getting what they need. It's just that the whites are overabusing. That has been refuted as well. So what about the system in which we work and our own role within the system? And here's what the Institute of Medicine came up with, that all patients, whether privately or publicly insured, should have sustained relationship with a primary care provider. Now let's look at what happens when we get graduating physicians into minority neighborhoods. Very frequently, it's because they received government loans, which will be forgiven if they stay in a underserved community. And some of you may have such loans and commitment. They're time limited. As soon as the 2 or 3 years is up, they're gone. So there's a rapid turnover of primary care physicians in underserved communities to the detriment of the community. It's already been pointed out in the very nice demographic slides, again presented by Dr. Shapiro, about need and facility being separated from each other. Where there's need, there's no facility. Where there are plenty of facilities, there's less need. Then, already mentioned, was increasing minority representation in healthcare professions. Community healthcare workers, very, very important. And I think in one of the pictures we saw, there was a church group, and where people congregate and gather are the places to, if you will, infiltrate and insert healthcare workers to disseminate information. And although this is not important right in our community, down in Canarsie and Brighton Beach, there are many people for whom language will be a barrier. We have to have appropriate translation services. So, speakers have addressed or will address the disparities as listed. That's on your program. in my remaining time, I'm going to focus on what we can do through surgical education to lessen the disparities. Remember, differences may exist. We want to focus on the disparities. And the other speakers will be addressing more specifically the cancer issues. And this is a chart from the Journal of the American College of Surgeons, and it tells us that we do have disparities and that they're multifactorial, and it's ring around the rosy, and in the center we have the result. They can be provider, patient. Well, patient, I think we're told that's sort of overrated. Post-op care, clinical care, system access. Well, we're talking about surgical education, and sure, we can learn about what's different, but what are some of the things we can do? And that's what that arrow was for. Anyway, here, get it back. There, got the green arrow. We can address provider factors. That's what we can do as educators. Now, a little bit of research on this. You know, it's nice to give an opinion piece, but expert opinion is sort of low on the scale of what we should be paying attention to. We want clinical studies, we want controls, we want higher levels of evidence. At Johns Hopkins, they've studied, expecting to find that they would find that there's bias and that bias influenced care. Now, why would Johns Hopkins think that there might be bias? Blood banking was introduced by a surgeon who was at Johns Hopkins. They had two banks, white blood and black blood. If you're white, you got it from the white bank. If you're black, you got it from the black bank. When the back blank ran out of blood, you were SOL, or out of luck. When the white bank ran out of blood, they took it from the black bank. If you were at Hopkins, you were not Jewish, you certainly were not black, and Tom Starzl, the great innovator of transplant, actually left Hopkins because he got fed up with that system. So Hopkins made major efforts to change. We all know that Julie Fleischig, they had a female chairman of surgery. We know that the Blaylock procedure, the first correction for the blue babies, was developed at Hopkins. Only years later did we learn that it was really done by his black technician, and Blaylock needed to call him into the operating room when Blaylock was doing the first one. So Hopkins has a bad tradition, and they made great efforts to try to change, and they started with a hypothesis that they're going to see that there is discrimination and bias, and in two major studies, they came up with surprising results. And let's see what that entailed. They studied their own faculty in one of the studies, and then they studied by a survey members of the Eastern Association for the Surgery of Trauma. And they had very sophisticated studies and validated testing using what's called race implicit association test and social class implicit association test, in which they could detect in a reliable fashion whether people had implicit, unconscious bias. And they found that people did, which is what they expected. Then they studied whether these biases translated into difference in care, because that's what mattered. Is it going to translate into differences in delivered care? And they fully expected that it would. Lo and behold, it did not. We're home free. Or are we? They studied scenarios that were given to the surveyed, and then the surveyed participants wrote out their answers. It was hypothetical care. That is different from real care, because we've seen all the numbers, and today you're going to see numbers that show discrepancies. Well, let's take a look at this a little further. Okay, this is the data from the Hayter studies. People said, I don't have any race preferences, I don't have any social class preferences, but the implicit association testing showed that they really did have preferences, which doesn't surprise us. But the surprising finding, as I've told you, was that it didn't appear to translate into changes in the way care was delivered. Did not seem to, based on their survey and the hypothetical cases. So, the biases were not significantly associated with clinical decision making. So, we've got people, they say they don't have bias, but we check it out, they have biases, but it doesn't matter. So, is there other evidence that there are significant provider factors in surgeons? And as things would have it, after I got this assignment from Dr. Grusner, I was just thumbing through my latest edition, or my latest copy, of the Journal of the American College of Surgeons, and I noticed this article, Impact of Race on the Surgical Management of Adhesive Small Bowel Obstruction. That's got nothing to do with cancer, but it has everything to do with how race affects a disease for which we no longer have the issue of access, because everybody who has the bowel obstruction is already in the hospital. So they've all gotten there. What happens to them once they get to the hospital? Does it matter whether you're black or white? We're not going to be dealing with genetic issues. We're not going to be dealing with the insurance status. They're already here. They're in our institution. So, one would expect equal treatment. This study was a very well-designed study. They used NSQIP data, National Surgical Quality Improvement Program, which is tremendously detailed. It gets all the characteristics of patients, a whole lot of data. And, although I'm not mentioning it here, it was over 13,000 available cases for study. And now we have a disease for which guidelines exist. Small bowel obstruction, we study them, we resuscitate them, we operate when it's appropriate. Standard, what we're going to do. Lots of cases, it's a common disease. Actually, it's a disease which we can take credit for because most small bowel obstructions are the results of prior operations that we've done. So, in a way, it's an iatrogenic disease, but forget that. It's a disease, it's common, it's the most common of our surgical emergencies that we're going to see short of appendicitis. The patients, as already mentioned, come in acutely. They don't get referred to specialty centers. They're not going to go off to Sloan Kettering. They're not going to get, these days, a ferry or a subway across the East River and go to Manhattan. They stay with us with small bowel obstruction. And once admitted, the studies that we do are colorblind. It's vital signs, blood count, lactic acid, flat upright abdomen, abdominal x-rays, CT scans. So, what did the investigators at Yale find when they looked at how small bowel is treated comparing blacks and whites? Overall, the mean time to surgery was 2.3 days. That the 30-day mortality for those waiting greater than 5 days for surgery was 8.2%, but only 3.1% for those who had surgery in fewer than 5 days. If the operation was done open, standard laparotomy, it had a higher mortality than if it was done laparoscopically. And although the mortality rates for blacks and whites was about the same, the complication rates for blacks was significantly higher than for whites. And blacks more frequently had open surgery than whites. Now, whether an operation is done open or laparoscopically is not generally determined by the patient. We determine who's going to get what type of surgery and advise that to the patients who are generally compliant with our best advice. So, a long wait's no good. Look who gets the long wait. That's a 50% increase. And this is adjusted, multifactorial adjustment. When the comorbidities are adjusted, the odds ratio for delayed surgery was 1.3. And the odds ratio for having your operation open was 1.5. All of this was statistically significant and based on almost 14,000 patients. What can account for these differences? All of the usual things, because they had so much data, all of this was controlled, and the difference still existed. Now we're going to say that's a disparity, not just a difference. So, the differences between the care of the whites and blacks reflected subjectivity in the clinical decision-making process. And these are decisional disparities, and it's decisional disparities that resulted in the differences in outcome. Now, what can be the basis. There may be systemic factors that whites cluster at different hospitals from the blacks. We know that. We already saw that as a fact, as Dr. Easterly explained, that the blacks are treated at lesser quality hospitals. I hope nobody thinks that we are a lesser quality hospital. We're doing our best to be high quality, everything we can do. But even when you control for hospital quality, and I don't want to knock another hospital in Brooklyn, but if I had an accident, believe me, I'd much rather be at this hospital than almost any other hospital in Brooklyn. But even at this hospital, there are some disparities. So maybe blacks had more complex small bowel obstruction. You know, maybe that accounts for the difference. So as a surrogate, as a substitute, because you can't say it was a tough case. Ask any surgeon who takes a long time, oh, my case was tougher than average. No, the case times were equal for blacks and white. We can't say the cases were tougher. Maybe they were distrustful. Maybe the Tuskegee effect was there. No. If that were, why did they end up with the open operations? And we already have said that that Tuskegee effect has diminished with time. So maybe we have provider bias. Can unconscious bias lead to differences in clinical decision making? Now, the Hopkins people thought that unconscious bias made a difference. And as we went through their paper, made no difference. But remember, the Hopkins paper was what people would do in a hypothetical situation. It was sofa research. They're sitting on their sofa and they're doing a survey. The Yale paper is real world experience. And not hypothetical scenarios, but what actually happens in clinical practice. So how can we address this? We have to understand and accept that disparities are real. There may be some differences, and remember in the slide, differences are differences. And when it comes to breast cancer, the fact that the black women are having triple negative cancer may in good part account for the differences in outcome. When a white person has a triple negative, she's going to have a worse outcome. A black person has it, she's going to have it. If more black people are genetically disposed to triple negative breast cancer, that's a genetic factor. We can't alter that. Maybe we should do research and get triple negative cancers better treated, and like they say, a rising tide raises all ships, the blacks and the whites together, for a terrible disease. So disparities is real. Differences may exist, but we have to understand that there are both overt biases. That was the way they gave out blood in the Johns Hopkins Hospital. You're going to bleed to death if you were black and they ran out of blood. You'll do a little bit better if you were white. That's overt. That's sort of taken care of. But do some of our biases result in decisional disparities? Do we do things differently? That's what the Yale paper very much suggests. Why do we do this? We don't want to. We say we don't have prejudice, but we do, and prejudices can come from the black community to the white, just as the white to the black. But if we recognize that we have biases, and when we have a bias, and especially when we're busy in a clinical setting, we fall back upon what are called priors. We fall back upon stereotyping and grouping things rather than addressing the one by one. It was pointed out that we can change communities, but we're dealing in a cottage industry one-on-one. And if we're rushed, if we're overburdened with too much in too little time, we tend to stereotype, and as soon as we stereotype, we're no longer fulfilling our obligation of treating the individual. So, we must teach that oversimplification and categorization can result in stereotyping with attendant worsening of bias. So, what's being done? This is just a little illustration pointing out that a few years ago, the American College of Surgeons and the NIH together had a major conference. We call it a major conference because you have all of these participants. And if you can see the picture a little bit better, you'd see that the participation is both gender and racially appropriate. And just again, since I was asked to participate, everybody in the community got this email. It went out to program directors, residents, and fellows, and not surprisingly, Dr. Salafu is there, and chairman of, I think this is radiology, and others are forming an interdepartmental committee to develop a curriculum with the intention to have this curriculum used across all departments, and they're starting by soliciting input. Another recent email, and this was alluded to, that SUNY has a major research grant dealing with supporting a fellow to get ongoing research in disparities and continue that research in order to continue gaining information. And locally in the Department of Surgery, we have a program directed by Dr. Robert Kurtz in which we are going to see just how these disparities play out right in our own hospitals affiliated and Kings County and University, and he's invited both the medical students and our residents to participate in this type of research. For those who have interest in further reading, I've just picked out a few of the salient articles, and then I'd just like to point out that the new face of SUNY is particularly suited to this. We are one-on-one when we operate, but public health goes community-wide, and the public health expansion here is a tremendous asset for effectively addressing the disparities that exist. Thank you.
Thank you very much. Dr. Kirichenko, you're next. All right, our next speaker is Dr. Natalia Kirichenko. She's going to be talking about disparities in the treatment of head and neck cancer. She's a Downstate original. She finished medical school at Downstate, and she went to Yale for residency and Memorial Sloan Kettering for fellowship. She's the chief of the Division of Head and Neck Cancer at University Hospital in the program, ENT department. We are very fortunate to have her participate in this conference, so thank you very much, and looking forward to
Disparities 2018 final. Go down, go up, go up, go up, go up, go down, go down. That's it. I want to thank Dr. Salifu and Dr. Grusner and Dr. Schwartzman for inviting me to participate in this very important symposium. The focus of my today's presentation will be disparities in head and neck cancer. First, I would like to introduce the topic of head and neck cancer. What do we mean when we say head and neck malignancy? Head and neck cancers can arise from upper air digestive tract, such as larynx, voice box, oral cavity, mouth, oropharynx, throat, or nasal cavity or sinuses. It can also arise from salivary glands, can arise from thyroid, parathyroid, skin, bone, and soft tissues. When we talk about head and neck cancers, we generally discuss squamous cell carcinomas of upper air digestive tract. What makes this tumors challenging is that the amount of anatomy that's going on neck up is pretty much equals to anatomy going in the rest of the body. No offense to general surgeons present in the audience. What makes it even more challenging is that the structures that we're talking about are such a big part of who we are and what we do as human beings. Breathing, swallowing, speaking, not to mention how we look like. Therefore, when we discuss treatment modalities in management of head and neck cancers, we not only focus on cancer cure, which is, of course, the most important outcome, we do also focus on function, form, and appearance following our treatments. Head and neck cancer accounts for 3 to 5% of all cancers in the United States. Worldwide, it accounts for 644,000 cancers, incident of cases annually, and 350,000 deaths annually from head and neck cancer. That's worldwide. Surgeons generally show pictures, not curves. This is pretty much the only curve I'll show in this talk, but this is an important one. This will allow me to introduce a topic of disparities in head and neck cancer. As you can see, mortality from head and neck cancer is fairly high despite all the advancement in treatment and research. However, African American and poor patients carry an unequal burden when it comes to the outcomes. Both race and living in areas of high poverty were independent predictors of worse outcomes, regardless of demographics, comorbidities, clinical characteristic, and treatment modalities. More importantly, in Caucasian population, as the poverty level increases, the outcomes decrease, which implies pretty much access to care. However, in African American population, there was no difference in survival despite poverty levels. And that has implications in exposure to risk factors, as well as genetic in tumor carcinogenesis in this population that is extremely important to understand. Based on current literature available, there is certain issues that identified that contribute to disparities in racial and socioeconomic disparities. Higher prevalence of HPV negativity within African American population, advanced stage of presentation, delay in treatment initiation, as well as treatment modality and compliance. I'm going to go over these issues in the course of this talk. The risk factor, traditional risk factors associated with head and neck cancers is smoking and alcohol consumption. However, this is on decline in our society, and most of head and neck cancers are on decline, with the exception of oropharynx cancer. The incidence of oropharynx cancer has actually been increasing, and you can see from the graph on the right. Human papillomavirus has been around for decades. However, its implication in head and neck cancers is fairly recent. As you can see, HPV-positive tumors are on the rise in our society. However, HPV-negative parallels the rest of head and neck malignancy on decrease. Therefore, we believe that increase in incidence of oropharynx cancer at this time is due to increased incidence of HPV-positive cancers. I want to use this opportunity to emphasize the importance of vaccination in HPV for eradication of HPV-positive tumors. This is one of the tumors that could be essentially eradicated if we vaccinate both boys and girls. Currently, vaccination of girls is mandatory in order to eradicate HPV-positive cervical cancer. However, to this date, vaccination of boys is still optional. And this needs to be changed. We would like to eradicate this cancer over the next couple of decades. So what do we know about racial differences in smoking and alcohol consumption? The data is mixed. There are studies that show that African American patients have high prevalence of both smoking and alcohol consumption. There is studies that show that smoking is equal, but alcohol consumption is more frequent, and yet there is studies that show that there is no difference. All these studies are done based on personal interview and retrospective data, so it's fairly low evidence at this point, but there is no significant racial differences that could be pinpointed in terms of exposure to these particular risk factors. We do know, though, that our patients are smokers and drinkers. The story with the HPV virus is different. HPV positivity and oropharynx cancer is substantially lower in African American patients. HPV positive tumors, patients with HPV positive tumors generally do much, much better, as these tumors are more responsive to chemotherapy and radiation treatment, to the point that there is protocol of de-intensifying treatments in HPV positive patients. The fact that HPV negative tumors are more prevalent among African American population probably attributes partially to their poor outcomes. What are the reasons that African American patients tend to be more likely HPV negative? There could be some behavioral factors in acquiring HPV. We know HPV is sexually transmitted disease, and though there is no studies showing that there is significant difference in these practices. In addition, there might be biological difference of progression from HPV infection to cancer. African American patients might be getting HPV, but due to some genetic factors, they are not progressing to cancers. So next a topic that we'll address is staged presentation. In general, patients with head and neck cancers present at a late stage. And the reason why is because very frequently patients don't necessarily have symptoms at early stages. Patient may present with hoarseness and be treated for things like reflux. Patient may present with atalgia and be treated for ear infection for a while. Throat pain can be treated with antibiotics. Nosebleed, a lot of early presenting symptoms are very similar to benign conditions, and cancers are not being picked up early. Certain cancers present early, certain cancers are more likely to present late, even within the head and neck scope. As you can see from these pictures, cancer of the vocal cord will cause hoarseness early on and prompt presentation to ear, nose, and throat specialists. So is a fungating tumor in the tongue, and therefore larynx and oral cavity cancers had been shown to be more likely to diagnose at an early stage. However, cancers of hypopharynx, which are more lateral and have less effect on voice and swallow function, or cancers of base of tongue tend to present at a lot later stages. And the case in point is Michael Douglas, who went very, very public in his battle with oropharynx cancer. He initially presented with throat pain, was treated with antibiotic. Then 3 months later, while his throat was still hurting, doctor gave him another course of antibiotics. Finally, 9 months later, his symptoms didn't go away. One of his friends, cancer survivor, advised him to go and see a head and neck cancer specialist. And that's when he was diagnosed with oropharynx cancer at stage 4. So even if, white Caucasian male who has access to best care had a significant delay in treatment in oropharynx cancer, we can imagine that our population will have delays with that respect as well. Therefore, it's extremely important to refer the patient to ear, nose, and throat specialists early, but they can get a proper oropharynx exam with bimanual palpation of base of tongue, and they can undergo in-office laryngoscopy to examine their voice box and oropharynx in order to diagnose this malignancy early. It's extremely important for primary care physicians, general ENT, dentists, oral maxillofacial surgeons to do head and neck exam when they ask the patient to open their mouth and stick their tongue out and feel the neck lymph nodes in high-risk population and smokers and drinkers. The tumor stage at presentation is the most significant prognostic factor. African American patients have been shown to present at advanced stage 3 and 4. And obviously delay in diagnosis and treatment permits cancer progression prior to treatment and therefore worsening outcome. Next, we'll talk about treatment modalities. So how do we treat our cancer patients? Head and neck is no different from any other malignancy when we treat our patients in multidisciplinary fashion. As soon as patient presents with suspected cancer, a team of specialists is built around this patient. That includes radiologists, radiation oncologists, medical oncologists, surgeon, pathologists, speech and language pathologists, as well as internists in GP. And then we discuss these cases in multidisciplinary fashion and make sure that treatment is delivered in accordance with NCCN guidelines in order to achieve best outcomes. Choice of treatment largely depends on a number of factors: tumor factors, patient factors, and surgeon factors. Tumor factors will include, of course, stage and presentation, location, its resectability. Surgeon factors is generally not an issue in our institution. Patient factors, compliance, convenience, costs, comorbidities, and so forth. Surgery remains initial definitive treatment to a number of tumors. Tumors of oral cavity and nasal cavity and paranasal sinuses is generally surgical disease due to ease of access and resectability. Advanced carcinoma of the larynx also remains a surgical disease, but for a different reason. We do know that when cartilage is invaded by squamous cell carcinoma, outcomes of organ preservation chemoradiation protocol is significantly inferior to surgical management, and therefore patients generally offer surgery as the best oncologic outcome. Yet in other modalities, we have choice of treatment. In early stage larynx cancer, both surgical management with laser CO2 microsurgery and radiation treatment allows equally excellent outcomes. We usually anticipate 95% cure rates with either treatment modality. Organ preservation remains mainstay in management of nasopharynx. oropharynx, and T3 of the larynx and hypopharynx cancer. The reason why is because access to nasopharynx is extremely complicated surgically and cause of morbidity in itself. Resection of base of tongue, soft palate usually results in significant functional deficits and inability to speak and swallow. And obviously with T3 larynx cancer or hypopharynx cancer, surgery of choice is laryngectomy, and there's significant social stigma and associated with this in our society. Organ preservation protocol generally entails chemoradiation treatment. This, however, has been recently challenged with transoral robotic surgery, which been implicated in diagnosis and management of oropharyngeal cancers. It allows better functional outcomes, and therefore is being used in HPV positive patients in order to de-intensify the treatment and potentially avoid radiation and or chemotherapy treatments, and in HPV negative patients with goal of improving outcomes in combination with chemoradiation treatment. So what happens with treatment modalities in African American patients? There's been studies show that African American patients are less likely to undergo surgery, and this could be due to a number of reasons. One is because they're poor surgical candidates due to their comorbidities, due to the fact that they present with already unresectable tumors or distant metastases, and that goes back to the fact that we need to really try to diagnose our patients early, and therefore they would more likely to undergo chemoradiation treatments in many instances with palliative intent. In addition, survival of patients who undergo surgery is also significantly shorter. We'll talk about delay in treatment initiation. This study was done in Cooks County Hospital, which is in many ways similar to our Kings County Hospital, which is public hospital. The bottom line, there is overwhelming amount of patients that we try to treat with limited resources. In this study, they looked at the latency to treatment initiation and also some of the factors that can increase this latency. Latency to treatment initiation was noted to have 7 weeks, and at advanced stage disease that required multimodality treatment, these latencies were even more prolonged. They created a timeline that underlines the event the patient have to go through from the time of suspected malignancy to the time of initiation treatment. Once malignancy is suspected by primary care physician, patient would see an ENC, would have to undergo biopsy, usually under general anesthesia. Pathologists have to come up with their diagnosis. Patient would have to undergo imaging studies, will have to be presented at multidisciplinary tumor board, and then finally the treatment planning, dental extractions, and treatment initiation. Delay could be both on institutional level and patient-related level. Institutional level delays could be due to availability of imaging studies, availability of specialty appointments and services, either appointment available in ENT clinic, radiation oncology, medical oncology, speech and language pathologies, a dentist available to provide dental clearance, operating room access, and dental extraction. Patient-related factors are medical comorbidities. Patient has a lot of medical comorbidities, will take longer to clear for general anesthesia, malnutrition, alcohol, substance abuse. Patient have to be off of his drugs of choice prior to undergoing surgery under general anesthesia, and of course, socioeconomic support. Even they took it a step further and found that patients who are undergoing organ preservation protocols are less likely to comply with their regimen and more likely to have treatment breaks. And we know that treatment breaks in chemoradiation treatment and poor compliance predicts persistent disease and recurrence. It's important to understand these factors, evaluate them at each individual institution, and come up with their ways to overcome these limitations. In many institutions, this is improved by utilizing mid-level support, such as navigators, PA and nurse practitioners, who can guide patients from treatment and ensure treatment compliance. So in conclusion, disparities are not explained completely by demographic comorbid conditions and undertreatment. Generally, we do comply with NCCN guidelines. However, early diagnosis is needed to improve outcomes. And this, we have to emphasize head and neck screening by primary care physicians, general ENT, dentists, and oral maxillofacial surgeons who need to perform a proper head and neck exam in high-risk population. More so, we need to examine potential differences in tumor biology in order to better understand these disparities at genetic and cancer tumor genesis level and identify better therapies. Thank you.
Thank you, Dr. Kirichenko. It is now my privilege to introduce our clinical keynote speaker, Dr. Farid Garagazlu. Dr. Garagazlu received his MD from Johns Hopkins. He did his residency at the Mayo Clinic in Rochester. Also, the chief residencies there in the Division of Thoracic and Cardiovascular Surgery. He went on to stay with the Mayo Clinic for a couple of years before he eventually became chief and professor at Georgetown University of their cardiopulmonary and thoracic program. He went on to also become the chief at George Washington University, and it was then in 2012 that I recruited him to the University of Arizona to build a robotic thoracic program there that, along with Dr. Poston's cardiac program, became the largest robotic program in the country. Dr. Garagazlu has moved on since. He is currently a professor of surgery at the University of Central Florida and surgeon-in-chief at the Center for Advanced Thoracic Surgery and within the Celebration System in Florida. Dr. Garagazlu currently serves as the president of the Society of Robotic Surgery and the director of the International Society of Minimal Invasive Cardiothoracic Surgery. He is the editor of over 200 publications. He is currently involved in the second edition of the textbook, the Springer textbook of robotic surgery, and he is going to talk to us today about disparities in the treatment of patients with cancers of the chest. Dr. Garagazlu, welcome to Downstate.
Beautiful, thank you. I think what you would agree with me sitting in the last few hours and hearing about these disparities in care, it's really depressing, right? I mean, it especially on this side of the room, you guys are the future of surgery and medicine, and you have a lot to do. But I tell you, I come from Iran. I also want to tell you that my father started in this borough, 1951. He came from Iran as an immigrant, and he did great things. So I owe a lot to Brooklyn and to what has happened in our lives. The issue is disparities are going to be there. We're going to work towards making them better. But I think that's more important issue for us is to be good doctors. I think if you look around the country, forget about racial disparities, sex disparities, etc., you'll find that we fall flat on our face when it comes to treating patients. Our patients are not happy because we're not treating them like human beings, and shame on us. This is a tough thing to swallow, especially on this side of the room, because we kind of get used to talking about these things in abstract. We talk about numbers, we talk about all these things, but the last thing we talk about is that one person who is sitting in front of us, and that is what I want to concentrate on, because if you fix that, you fix it all. It doesn't matter what color they are. It doesn't matter what sex they are. It doesn't matter anything. Shame on us that we have let our history affect how we treat patients. So I'm going to talk about lung cancer. But I'm going to tell you that not only am I going to tell you what the problem is, but I'm going to tell you how you deal with the problem. And that's what America is all about. So lung cancer is as you can see, a significant problem. It is the #1 cause of cancer-related deaths. Men and women. More patients die of lung cancer than all of those cancers that you can see. We talk a lot about those other cancers, but somehow this is the unspoken truth. You know why it is? In America, we want to be winners, and we have not won with this. We have made a lot of changes. This is the one cancer that we can't lick. I'm going to tell you how we're going to lick it, but we haven't done that. Look at this. Over 200,000 people get lung cancer, and 155,000 die every year. We don't do very well, right? And the important thing is that it is 26% of casts and deaths. New York, look at this. Now, there are almost 14,000 new cancers in the state of New York. The red is Brooklyn, 1,800. You should be doing 1,800 lung cancers in this institution every year, whether it's surgery, whether it's medicine, and so forth. Certainly, we saw the numbers from my colleague, and that's not the case. If you look at the important issue is that it's an equal opportunity killer. Lung cancer doesn't know disparities of anything. It just kills us all. And if you look, certainly it is more common in white men and so forth, but that's irrelevant. The issue is the one thing that comes out when you're talking disparities with lung cancer is the socioeconomic status of the patient, whether they're in Brooklyn, whether they're in Appalachia, whether in the South, in the Southwest of the United States where I went at the University of Arizona, it's inversely proportional to the death rates. If you're poor, you die of lung cancer. And that, I want you to think about how you change that. That's the problem. And of course, tobacco use is significant, but there are many other things. Plenty of cancers in non-smokers. Unfortunately, it seems that there are factors, there's estrogen in women that affect lung cancer. And then, of course, as we get older, no matter what race, color, creed, whatever, as we get older, lung cancer becomes the issue. I want you to look at this study. This is a recent study. This was done in Dallas, UT Southwestern. They looked at stage 1 to stage 3 lung cancers. And they looked at standard treatment and other treatment. Now, the more experienced practitioners in the room can tell you that we don't treat disease the same way. There are so many factors. I loved your discussion that the provider factor is significant in all these things. We carry so much baggage. And what happens is, if they can pay for it, as it comes out in this study, is a significant factor. So it is interesting that your survival not only depends on age, gender, sex, the treatment, but on your insurance type. Shame on us, all right? And the standard therapy, you give it to somebody who has insurance. So this is not a problem of Brooklyn. This is the problem of America. And this is what we're talking about. Now, people get older. Look at this. 74% of our patients all come to us when we really can't do much for them. Stage 3 and 4, survival is not very good. You got to ask yourself, and I speak to this side of the room again because you matter, and the question is, why? Why is it that these people are coming to us very close to dying? Why? Why is it that 70-some% are high stage? And you can see the survivals. If they're early stage, there's nothing magic about lung cancer. You know, the women of America in the 1970s said, we're not going to die of breast cancer, right? All kinds of things happen, they live with breast cancer. It's the same thing, but it's all about early diagnosis and early therapy of a disease that's not out of control. This is not rocket science. We have seen it. So when it comes to lung cancer, take a look. 88% of these patients, if they're stage 1, will survive 10 years. That's a cure in that age group. So what is the problem? And the problem is that you have to marry various things. This, again, comes to that one patient. The problem in medicine is we like to talk. We like to show studies, we like to discuss the problem, but we never come with solutions. And in lung cancer, the solution is not a surgeon or an oncologist and so forth and so on. It is everybody. You have to screen them. You have to definitively diagnose. For my young colleagues, don't ever watch something. Watch in medicine means you don't know what to do, right? Don't watch it. You have to understand it, and that makes a difference. Diagnose it, and then you have to give them surgical therapy. That I'm a surgeon, so we're talking surgery, but surgery that is less invasive so that they can survive. Now, we're going to go down this line. So the New England Journal of Medicine article, 2006, survival of stage 1 patients with lung cancer with early detection with CT, right? It has now become almost second nature. People all talk about this. And there's a lot of data that came out after that specific study. But look at that study. In that study, when they screened these patients and they picked up lung cancer early, if you operated and removed the tumor, the 10-year survival was 92%. However, 8 patients decided not to have surgery in that study with early disease. What happens? They die. And so you see what's going on. It's the early detection that's key. I mean, that's, again, very straightforward. Now, a lot of other work was done. A lot was done at Cornell, et cetera, but the point is a lot of work was done to get to the point where we understand that lung cancer mortality will decrease with low dose CT screening. A lot of data. And the amazing thing is that lots of organizations, surgical, non-surgical, whatever, came up with recommendations for early screening. Then the question was, who's going to pay for it? You know, again, it's always about the money. And then what happened is all of these commercial payers decided they would pay for it. Medicare decided that that would be fine. But now, and then we made the recommendation that if you're over the age of 55, 30-pack year smoking history, and quit in the past 15 years, you need annual CT. That should be the state of the art. That is the state of the art, that is the practice, that is the recommendation, right? 2013 this was done. Here's a study that just was presented in ASCO. Look at this. 1,800 screening centers around the country. 7 million people who are eligible to be screened, and we only screened less than 2%. Shame on us. Now, the question then, the academic question is, why, right? And then people come up with all kinds of things, and usually, again, I'm trying to make a point, but usually, if we fall flat on our face as physicians, who do we blame? The patient. Not so good, right? And so we will say there are system barriers, there are provider barriers, there's patient barriers. These people want to die? Are you kidding? No. The barrier is we didn't put this thing together. And we have this. This is not theory. This is what we did in University of Arizona. This is what we've done in Florida, and this is my life. But the bottom line is, to do this, it needs to be part of a multifaceted thoracic oncology program where you know where the people go once you have done this. From a practical standpoint, that referring physician who sees the clinician who's seeing the patient and sends them to get the CT screening, opens a Pandora's box for his practice if you don't have a system. And then, you know what? They don't send them anymore. Then the patients don't go. Patients like, I had the screen last year, you didn't do anything about it. Why am I going to do it again? This is not joking. This is the truth. This is the state of medicine. So look at this. Now, I trained at the Mayo Clinic, and before the studies with the CT at the Mayo Clinic, this is a very famous study. My colleagues know, the Mayo Lung Project. They didn't have the same capability, but in the 70s and early 80s, they looked at chest X-ray and sputum cytology to pick up lung cancer, right? And they said, at the end of the study, there was no benefit to survival when it came to early screening. Why do you think that is? Because they didn't do anything about it once they diagnosed the problem. There was no intervention arm to the study. So that becomes a very academic exercise. When they followed these patients, this is a new paper from a few years ago that followed those patients from the old Mayo study. Basically, you can see if for some lucky reason that patient moved out of the study and had an intervention by way of getting that lung cancer resected, median survival was 16 years. So there is a survival advantage. You just got to do something about it. So again, not to beat a dead horse, but the bottom line is screening works only if you do it and you make an intervention. That's it. It's not going to work otherwise. So let's go back to 1970. Again, talking about how we just like to talk in medicine and talk about describing the problem. So here's a quote from Dr. Carbone, this was an NIH conference published in 1970 in the Annals of Internal Medicine. At present, lung cancer is recognized late. Opportunities to improve survival are through early detection, accurate diagnosis, accurate localization, and curative therapy. Wow. Has anything changed? No. That is disparity. That is truly the problem of lung cancer, and that, you just got to talk about it. The king has no clothes. That's the truth. Now, that's a program, talks about those three things. About aggressive screening, definitive diagnosis, early surgical therapy, and I'm going to take you down this journey, which has been the journey of part of my career. So the lung cancer program needs to have at least the things that you see on there, and more. This is not about the surgeon. This is not about the oncologist. All kinds of people have to get into this program because the bottom line is you are delivering a product. And I tell you, this is the problem of medicine, ladies and gentlemen. The product we deliver is no good. I'm sorry to say it. There are very few institutions in this country that provide the right product. Our patients come to us and they make a covenant. I get goosebumps saying it because this is a religious experience, and we let them down. And the reason we let them down is that we don't take their problem onto us and take care of it. Our system is behind the times. We are not where we need to be in terms of taking care of that one person. So that's what a program does. Now, if you look at it, basically, these are the pieces of a lung cancer program. You find the early disease. You diagnose this. You do not watch it come back in 6 months. Surgical therapy of early disease. Multimodality therapy of advanced disease. This is what happens. And when we did this in University of Arizona, they did 70 cases, just to give you a palpable feel for what happened. In 3 years, we went from 70 cases to 560 lung cancer cases operated on, and so many more that came into the oncology world. That's because we provided a product that the patient wanted. And if you look at the lung cancer program, and you look at it starts with the interest and it becomes a real program, it becomes a significant part of any medical center because it involves every piece of a medical center, not just surgery. Now, diagnosis is key. The problem is a lot of disparities are there because the patient basically doesn't get the right care. So let me see if this is. So this basically shows you the concept of navigational bronchoscopy. You need this. You can't just, if there is something in the lung, you got to know what it is. And the cases where you can't really know should be very far and few in between. This is not about come back in 6 months. So once you know this is early disease, then the next thing is we have been doing an operation that now for almost a century, the thoracotomy, which is another disease unto itself. So you can't take somebody with a thing that they don't feel, right? You just found it. They don't feel bad. I have so many patients that, why are we talking about this? I'm fine. And the thing is, when you think you're not fine, you're not fine. You're going to die. So the issue is the surgeons have to come to the table. And that's been the work we have done. And really our holy grail is how do we do the gold standard thing, the operation, which is lobectomy and a nodal dissection and all of that, without putting a patient through a thoracotomy. Now, why are we interested in this? Why do we want to do not a thoracotomy? And there's a lot of data. Basically, our patients die of a few things after thoracic surgery. They'll die of a PE, a heart attack, a stroke, infection, right? Those, I tell you, are all created by us, by the way we went in there. So unfortunately, our patient comes with one problem, and then we give them all these other problems. So the immunity has to be enhanced. So you can see, I'm not going to go through all the data, but the bottom line is the thoracotomy incision is a disease. And if you think about it, as the animal in the I don't know, deserts of Arizona that's roaming around, and the next thing, in Arizona, everything eats everything else. I mean, that's what I found in 3 years. So as that animal is going to get attacked and the piece of its body is taken away, what happens? It has to survive by clotting. If it doesn't clot, it's going to die. So clotting is evolutionary, from an evolutionary standpoint, a preservative thing or a preservation of the species. But in surgery, no good. So when we operate on the patient and we cause the trauma of a thoracotomy, and there's a lot of data for this, we are basically setting forth the cascade for early clotting. And you see the complications. And then the other part of the cascade, and there are a lot of people like Dr. Salafu who are smarter than I am about this, but he'll tell you that the other part of it is that your immune system goes through the bottom of the floor, and now you get infection. So the thing is, how do you stay under that radar screen? That is the message of minimally invasive. We are not talking about go back to work earlier. We're not talking about less pain. Those are fine. We're talking about survival when we're talking about minimally invasive thoracic surgery. And then the next thing is, since your chest wall mechanics are key to breathing, you cut the chest wall, you're going to have issues with lung function. So now, I wrote a chapter in our thoracic book and early in my career that had to do with the rules of when you do a lobectomy. You remember? Oh, FEV1 has to be this, You can throw that into the garbage because it doesn't mean anything. Those are the rules of what happens when you cut somebody's chest. You don't cut their chest, their FEV1 is not going to go down, everything will be fine. So, and I've been through this journey. We started by VATS. We were talking earlier about our experiences and so forth. Video-assisted surgery in the chest was all exciting in the 90s, but we found that there were a number of problems. We really didn't have the technology to be able to do what we can do with an open incision. So we cut corners, and that is a horrible thing when it comes to oncologic surgery. And for you, the younger people in the audience, do not sacrifice the oncologic efficacy for minimally invasiveness. That's garbage. The rules have to stay the rules. You have to find the technology to be able to do what you do as an open way that's been done 100 years now. So there are a number of problems with VATS. So we decided that we were going to go and be scientists and really start with a clean sheet approach to this problem. And a clean sheet approach does not mean one thing. You take the problem, you divide it into its component pieces, and you answer something about all the components. So we had to relearn the anatomy. A chest surgeon sees anatomy from one direction. The camera comes from other direction. You got to know that anatomy differently. You got to understand the cameras. You got to understand the devices, the endosuturing, on and on and on. This is more for a surgical audience. But the bottom line is, you have to take it, answer every question in the pieces, and then put it together, and that's when the product is good. That iPhone that everybody in this room is carrying is a series of little products that have come together to make this amazing device. That's surgery. And you know, we don't take surgery seriously enough. To me, this is a religion, and it should be to every surgeon in this world. This is not a job. This has to be perfection or nothing at all. So, lots of instruments. I would like you to see, these are all worked with Dr. Lewis. We were talking about Dr. Lewis. These instruments were designed with a friend we have, and basically these are this different instruments to allow us to do surgery to little holes. And then the next question was air leaks. And frankly, the issue here is, I have to give Dr. Grusner credit for this, because when I was at University of Arizona, he had a program for ideas by surgeons that could then come to fruition and to the market. This product is a healing accelerant. So when this produces a fibrin layer, just as if your body is doing it, within a minute versus a week, and this is now on the market as of a couple months from now by Baxter. This is a product of our work at the University of Arizona. And then issues of pain. Forever we've been putting epidural catheters and then giving people pills. Has anyone had a thoracic incision in this room? It's like getting shot in the chest. And you're giving a couple pills to this poor guy and you're letting him go home. No, there has to be better management. And if you don't do that, then when his private doctor or whoever has referred him to you sees him in agony, it's the last time he thinks of surgery. It's the last time he thinks of picking up lung cancer early, because that's what happens. The product, when they walk in the office of their referring doctor, needs to be right. And then they'll get excited, and there will be others that come. There is that piece of it. So this is a way of putting these catheters right on the intercostals. If the pain is in the intercostals, and they're numb for 10 days. We got this idea, my wife is a dentist, and you can go to the dentist and they can give you morphine and you're not going to be comfortable. But if they're numbing it, you're good. And my wife is very successful. I don't know how good she is as a dentist, but she's really good at numbing people. And then they think she's really great. And so the numbing is an important thing. And this idea is, if your chest is numb, you don't care what's going on. And that's what we did. So there's a whole different way of dealing with pain. And then the next thing is, who said that if you have a chest tube, you got to be stuck to a thing in the wall and walk the halls of the hospital for a week? Because your hospital administrator, the gentleman who was here earlier, he hates you, right? A week because you have an air leak. Well, if you have a healing accelerant, you decrease the air leaks. And then you have a chest tube. This is one of our own inventions. That's a chest tube system that has internal suction. They go home with this. That thing you go home with. Then you come, it's a drain then. They come back to the office. You're not sitting in the hospital so long. And that's how you produce value for people who are counting the beans. And then finally, the issue is this, the surgery itself. Now, the surgery itself is VATS. right? And it was pretty good for the 90s. There aren't many things we do now that we did in the 90s. And so that is this guy. So VATS is done, what? You look at it on a TV monitor, two-dimensional. Chest surgery, everyone can tell you, the chest is a very three-dimensional structure. You need 3D. So VATS surgery is as if the surgeon walked in the room with a patch on his eye. How many of you would run out of that room as soon as your surgeon came with one eye? Right? That's VATS surgery. And it's the truth. Now, this is also VATS surgery, no hands. VATS is like little sticks, you stick them in there and you're manipulating. How can you do chest surgery the right way, the way that our ancestors did it, and the people who came before us without hands? If you had a surgeon without hands, you're in trouble. So the concept was, how do we get three-dimensional visualization? How do we get instrument maneuverability in a confined space? And this goes back to 2000. This is before people were even knew the word robot. This is when I was in Washington, and this is where we were lucky to be at the earliest phases of the robotics. And basically, we started to apply robotics and the other thing that's important is, why do I have to be a two-handed surgeon? You know, when we do open surgery, you have an assistant who is working with you. That means there are 4 hands at the table, right? Why do I need another person? I can have my own 4 hands. And that is the magic of this technology and this platform. But then without a person there, the synapsing is so much faster. I don't have to tell him, move. I just change my hands and do it. And so the surgery goes faster, the anesthesia time is slower, and so forth and so on. This is complex robotic surgery. So marrying the surgical robot really to this allowed us to replicate the open anatomic lobectomy, which is the gold standard. And I'm not going to go through all this in too much detail, but basically, this is cancer surgery. This shows you a total mediastinal exoneration. This is not sampling, this is not looking, this is removing every single node in the different stations of the chest, because, as I'm going to show you, sometimes there's a lot of disease you don't know about. The next thing is, so the way the robot dissection works, and I'll show you a video, it's dissection of the artery, and it's all their branches, then the dissection of the vein and the hilum, and then we basically divide. And now our robots have gotten better so that we can actually divide as we go, because now we have staplers for the robotic arms. We first wrote and I want to go into the academic side of our world a little bit. We wrote about this experience, the first in robotic thoracic lobectomy, published in 2006, 30 patients, not many. And then in a couple of years, 100 patients. And this paper I'm very proud of, because this shows the learning curve. One of the things that you have to understand is, unfortunately, we learn from our patients. That's the truth. And they need to know it. And so the issue is, and you need to share this. You know, you don't see too many papers in the literature that talk about negative things. You know, we're always winners. No, there's truth to this. So this is the learning curve. It actually was 20 patients. So we said, you know, in 20 patients, you're going to do it. If you haven't done 20 lobectomies, you can't do this. And then 300 consecutive papers. We wrote the first textbook of robotic surgery. And the reason I show this is not to sort of blow my own horn, but to tell you, look at that. It was selected by the British Medical Association as the textbook of the year. They understood the power of the robot. I promise you, one of these days in September of God knows which year, your radio, you're going to turn it on, and they're going to say, the robot got the Nobel Prize. Because this has changed surgery. It truly has changed surgery. Now, our second edition is coming out, and I want you to see there are some familiar names on the editors. Drs. Poston and Dr. Gusner were working on this. It should come out in next spring. And The thing is, and this is the latest paper we've written, this is the largest series of robotic lobectomies, 867 patients. We've done over 2,000 robotic operations of the chest. And I want you to see the results. This is, again, trying to let you see that you cannot just talk about one thing. You got to start from the beginning. You got to find the problem, identify the problem, deal with the problem. That changes the whole world. And so if you look at this, don't worry about all the details, but basically all kinds of resections are done. And if you look, the 83% of these lobectomies were cancer. And if you come, look at this. Mean operative time is 3 hours almost. That's pretty quick. Hospitalization, 3 days. The hospital administrators love that because no matter what, they're going to get paid for at least a week. That's how the DRGs go. 4 emergent, so 0.5% of emergent conversion. So the idea was you don't convert because you can't do the operation. You got to learn ways of dealing with problems. But look at that. 6% of the patients have major bleeding issues, and we have all kinds of tricks, which is, again, for us more of a surgical discussion of how you deal with bleeding. The days of sewing stuff and stapling stuff are gone. Those are, history. And then very few complications. Look at this. Overall mortality of 0.2% and no deaths in the last 865. The first 20 patients had 2 deaths. So beware of the inexperienced robotic surgeon. That's the truth. And that's what happens because our system of medicine puts an experienced surgeon and an inexperienced surgeon in the same boat. The patients complain. The patients say, I want someone who has gone through that learning curve. And if we can't offer that to our patients, we are letting them down. And that's another problem in medicine. And that's the truth. We've all become providers. I hate that word. Now, look at this. 18% of the patients, as a result of the good cancer surgery that you can do by removing the nodes, were upstaged. This is microscopic disease, not detected by PET scans, by EBUS, by nothing. And these are the people who would die because you wouldn't recognize them until they recurred. Or they really don't recur. It's the same disease. It just grows. So these are the people that if you give chemotherapy to and radiate them on occasion, they will survive. Look at the survival statistics. We're talking almost 5-year survival. This is not actuarial. This is real. We'll follow them. Survival is 99% in these patients with early stage lung cancer. What a difference in statistics. That's the power of a program, not just surgery. Now, taking this one step further, and we're almost done, taking it one step further is there are a lot of people who smoke, they have COPD, they got bad lungs, and you hear this all the time. Is he a surgical candidate because his lungs are not so good, right? What? That means that who said lobectomy is the answer? So the lung has many segments, and anatomically, they are just like a lobe from a lymphatic drainage, everything. It's just technologically we can't do it. And to be honest, the segmentectomy, even open, is a very difficult operation. But the robot, once you got the magnification, the 3D, and you're in with the little hands, you can do this. So this is a paper I want to see. That's the better Dr. Grusner on this paper, who did all the statistics for this, and this is just coming out. And it's the result of the anatomic segmentectomy long term. And really just, look, these are people with FEV1s of less than 1,000. You would run away. They would be getting radiation, all of these things, God knows. I love it. See, you know all these. I can tell the experience. So anyway, if you look at this, the operative time is even faster. These are sick people. It's a lot better. The median length of stay is 4 days. These are sick. You can see they can stay around. If they get an infection with those bad lungs, they're going to be around for a while. Only 4% were planned conversion. That is an important point, that you can't, as a surgeon, you got to put your ego aside. You go in there, and this is not possible. Do the right thing. Open the patient. Don't just sort of muck around there because it's supposed to be minimally invasive, which is, again, what happens a lot. And then no emergent conversion and 0 90-day mortality. That is a big deal in these really, really sick people. And then if you look at these, 14%, it's interesting how the numbers kind of hold up, we're upstaged. And then the follow-up is 54 months, and I'll just show you some curves, courtesy of Dr. Angelica Grusner, that basically, if you look, the overall survival for cancer-specific survival is 55% for these patients. That's amazing. Very, very high. And if you look, if you don't upstage them, their survival is fantastic. If they get upstaged, they die. So it goes right back to what I was saying. If you don't recognize the disease is going to go. And that's very clear. And then if you look at the cancer-specific survival without upstaging, it's 63%. Very good for these people with no lungs, almost. And then that's basically the same thing. So, and then really in this, it turned out that upstaging and age were the significant things. So, to make a long story short, and I appreciate you listening to me before lunch, I'm going to take the chance to editorialize a little bit. So if you're going to make an impact, whether it is with diversity and all kinds of problems that are all over this world, you got to do medicine the right way. If you're doing medicine the wrong way, it doesn't matter what your intentions are. And I think that's an important lesson to every single medical school in this country, because I think medical education needs to change, and I think medical practice needs to change. That's why there's only one Mayo Clinic. People always talk about Mayo Clinic because they were way ahead in putting the patient in the center of this universe rather than everything else. So a comprehensive lung cancer program does that very thing, as we have discussed. And finally, just 1 minute, we get numb to numbers. You know, how many times do you hear 100,000 people died somewhere, 2,000 people died of this? These numbers don't mean anything after a while. But the young people in this audience, it's about one. This kind of statistics is mind-numbing. It really does, you know, it's meaningless almost, because even 1 is too high. And then when you think about that person, then you deliver everything I said in this environment. This is what I learned at the Mayo Clinic. You know, I had a tough time deciding whether to stay at Hopkins or train at Mayo Clinic. Last minute, because of various family things, my father trained at Mayo Clinic, so, you know, he forced me. And I went kicking and screaming, the best thing that ever happened to me, because I learned this. This is what you were talking about earlier. They don't have this. They have it now at Hopkins, but they didn't have this at Hopkins in the 80s. So it's an environment of compassion, respect. Our patients need to feel like they are human beings. They are not diseased entities. And if you're going to make an impact in Brooklyn, in this country, in this world, this needs to be the nucleus of everything you do. And it is the one person that's important. And I think there are a lot of wise people in this world who have said what I said in a much more elegant way. Thank you very much.
The compassion, everything else that comes with it. Thank you. So now that our speakers are here, any questions from the audience? Dr. Rosen.
A question, because we are, I think, mistaken in thinking that by me talking, you listening, you're going to be able to do what I tell you. History shows there's the concept of apprenticeship. You know, when I was a student at Hopkins and I was thinking about doing residency at the Halstead, which is like, you know, the Mecca, right? It was like, okay, if you're an intern, you do appendectomies. If you're a second year, you do gallbladders, et cetera, et cetera. And that is okay if you're Halstead in 1902. But that's not okay now. right? It's not okay for our patients, and it's not okay for us. We're not experimenting on people, right? So the Mayo Clinic approach was apprenticeship. You could be 80 years old. If you can't do an appendix, you shouldn't do an appendix. You see? So that's a different thing, and that's how we have done this. So teaching needs to be someone who's experienced, who can take you through the pieces of an operation, but always ensure that the end result is the right result. So I really don't like the way we have taught surgery in the past. And I think that there's a lot of that kind of baggage that we carry. Concept of surgical education and training needs to change. And I think that that's how we will serve our patients, and you know what? Ourselves too. There's nothing worse than a surgeon who feels uncomfortable about what they're doing. Thank you for the question.
Dr. Kurtz?
Dr. Woodman mentioned Adil Hader's paper, which I read when they came out 3 or 4 years ago. The ones on the Hopkins results on bias and trauma. And it took me a minute to figure out why those results were what they were. The bias showing according to the sophisticated tests they use, but the results not showing any difference. And I think the answer is, in that study, it's really selection bias. It's a non-random selection of subjects, all of whom are trauma surgeons doing trauma surgery, whose outcome is pretty much, and whose course is pretty much predetermined the minute the patient comes in. Patients in the emergency room with a penetrating trauma of the abdomen through a gunshot wound, that patient's going to be operated on right away, whatever their ethnic or racial or financial background. And there isn't that much, there's no consideration, basically, of planning an operation, discussing things with the family, figuring out one course of action versus another, getting this or that imaging study. I have a feeling that if that study were done in, say, complex cancer surgery like Dr. Serafini does, not saying he's biased, but that kind of decision-making, much more complex before surgery than with trauma, or at least much more antedating the time of the surgery, there might be a different result.
Well, that would be true, Bob, if they would looking at the outcomes of trauma, but they were looking at the outcomes of adhesive bowel obstruction. These were not, this is because the trauma surgeons are doing acute care surgery. Once the patients came into the hospital, then it was all decision-based over the next 5-10 days. So it took out the absence of access. Everybody had access, they were there. It strictly was based on the algorithms that they followed, because the surgery is no longer emergent, it's urgent, semi-elective. It is a fair description, at least in my estimate. It's not like cancer surgery where you can choose to go to the bigger center or you can delay. You can have various modalities beforehand. There's no treatment other than the nasogastric tube and time. It's when the patient finally gets the decision made, and that's where the discrepancies showed up. So I thought it was a fair choice, even though it was trauma surgeons who were being surveyed.
You confirmed what I'm saying, but I just think trauma surgery, even though that's what I've done, is a bad choice with this study, because we're going to pretty much do what we do 100% of the time. But even with bowel obstruction in the real life study at Yale, there were differences. I don't disagree with you. I think completely agree.
Dr. John?
Thank you all for coming in and discussing a very complicated subject. And the issues here that you all mentioned, and the word that comes to my mind in all the presentations is intersectionality of problems and the conglomerate of a process called disparity. And that is, as the initial speaker talked about issues of redlining, policy, procedure, law, you look at studies out of Yale, look at kindergarten, children, black males, are 10 times as likely to be expelled from kindergarten than any other group. That starts your bias. Therefore, we have no pipeline. That in itself affects all of us. And one of the comments that we are looking at the Band-Aid effect. How do we address our problem that started before any of us were born or even thought about? How do we address it? On an individual basis, a programs like this is great, but we then have to adjust our process and our thinking, how we deal with our patients, and how we address them individually to ensure. I won't attempt to say your last name because I'll make an ass of myself. We have to address each one with compassion to ensure that they get adequate care. And the institution or the groups or the educators provided also have to do this. I know I'm preaching because this is a practice I deal with on a day-to-day basis. Dr. Bruce, I've seen you speak and address this issue from the point of view from the providers about transplantation. This is an issue we've been dealing with on a continuous basis for the last 30 years. Thank you very much.
Thank you, David. I just wanted to give our two female speakers an opportunity to answer one specific question. How do we overcome disparity in what we are doing from the surgeons and from the physician's perspective? Dr. Shapiro first.
So I think that education is key. Most of our patients, as I show you in the slides, and based on research we did on our population, they're not complainers. They don't complain. Now, we all know that there is a proverb saying the squeaky wheel gets the grease. So maybe that delay of 2 days or 1.5 days in surgery is because, you go to bedside and you ask, Miss Johns, how you doing? She says, thank God, I'm doing well. Her respiratory rate is 30. She has fever, right? So we gotta teach our patients to complain, number one. Maybe we have to teach our doctors to ask specific questions. Are you short of breath instead of how you feeling? I don't know, but it's much more than, yes, there is an implicit bias that's demonstrated time and again by research. I think that also putting creating guidelines that are population specific. For example, look at our sepsis. If you look at the SOFA criteria, paper just published, they don't apply to black individuals. Our patients' regular white blood cell count is 2.43, right? They come with white blood cell count of 8. It's still normal. I've seen it time and again documented in charts. White blood cell normal, the patient cannot be septic. No, that patient white blood cell doubled. So we don't even have textbooks that address what's going on in our population. So again, education, that's the key.
Dr. Kirichenko.
So I'm going to talk about head and neck cancer. In head and neck cancer specifically, early diagnosis is a key. So, and this could be overcoming disparities in early diagnosis could be by educating community physicians, educating primary care physicians, general ENTs, dentists, to do a head and neck exam and feel for the lymph nodes, look in the patient's oral cavity and throat in a high-risk population and smokers and drinkers. Another point that we can address is decreasing the time from diagnosis to initiation of treatment. And that's something that could be done on an institutional level by improving availability of services and also potentially investing in mid-level providers such as navigators, nurse practitioners, and PAs who can streamline and coordinate care between a multidisciplinary team, and also monitor treatment compliance and improve patients' compliance with the treatment, avoid treatment breaks, and improve outcomes.
Thank you very much. I think we'll leave it at that. We have been here for as long as Dr. Garagaslu was mentioning a lobectomy in the OR takes 200 minutes. Unfortunately, we have not been under anesthesia, so there are a few lunch boxes out there. And then I would like to ask you, the residents and the medical students, to come back for the afternoon session, primarily about abdominal malignancies. Dr. Mathusamy and Dr. Schwartzman will monitor this session. Dr. Mathusamy and I have talked about this issue of disparity many times on both sides of Clarkson. Both at Downstate and Kings County are in a unique position. And again, as we are working with Dr. Salifu, he has been able to attract a lot of attention on part of the NIH for the diversity and everything that we stand for at this institution. And I hope that ultimately we can develop similar programs and grants as to what we have seen in internal medicine. I'll stop here. I'll let Dr. So we're already running 30 minutes late, so we'll be back at, what time is it now? Now let's make it 1:15. We'll be back at 1:15. Thank you.